would like to thank Professor Dr. Reem Ahmed for gathering all of these summits of expertise from all over the world to join one of the most important session. I call it for the oncologists because I'm by definition clinical oncologist, but by heart I'm a radiation oncologist. So let me ask Dr. Ahmed Abdel Halim to the stand as a chairperson and allow me to start right now the first speaker, a little shift. We will start by Dr. Ihab Khalil, National Cancer Institute, Nasser Institute, Evolution of Radiotherapy at Nasser Institute Cancer Center. Dr. Ihab, please.
Thank you very much, Dr. Khalid, for the presentation, and thank you for the attendance. I'd like really to thank Dr. Yasser Abdel Latif, Dr. Ali Husni, Dr. Ahmed Mustafa, Dr. Sharif Hassanin, Dr. Radwa, Dr. Medhat Sibaa, and Dr. Rimon for allowing me to present first because I have a commitment. Actually, evolution for radiotherapy in Nasser Institute, we started since 30 years, and thanks for Dr. Arim and Dr. Khalid, and thanks to the NICC team members, from the medical physicists to our colleagues, to the nurses, to the workers, and to our patients and to our students. This is the first slide that radiation therapy and any service in health is a team work. So it is the team, not the beam. Really, I do thank all the team members of NICC. And these are the team members, our physicists, Ahmed Musa, Asma Muhammad, and our radiotherapists. In NICC, we had Siemens, Encore therapy machine. Then we imported the Synergy. And since then, we started the 3D conformal, followed by the IMRT, followed by the IGRT. We don't have brachy. And then we implemented SBRT, SRS, VMATs, and DCATs because we have the Monaco. So this is the evolution of radiation in NICC. I will start by an introduction, then some clinical examples and some videos. The new technology and the biomarkers are the step ahead now to personalize radiotherapy or to personalize even immunotherapy for the clinical oncologists. So how to improve radiotherapy? We have to improve their treatment outcome and the quality of life. How? By decreasing the side effects and hence the mortality. And this is very well shown in the breast cancer. This is a very interesting article since 1984. When and how can we improve precision in radiotherapy? So it took them 40 years to work on improving the precision of radiotherapy. And this is how the evolution starts. A notion, then you work on the notion, put some aims, and then some steps towards success. Precision oncology is a physical normal tissue sparing, target volume concepts. As we all know, imaging plays an important role. Conformal planning, increasing the dose to the target with minimizing the dose to the neighboring structures. And without image guidance in the high advanced technology, we are losing. You might be giving the dose to another area because you are giving a highly precise, small volume tissue with a very high dose. So the accuracy in radiotherapy can be achieved through a very well-designed delivery process, starting from simulation, ending by IGRT, and minimizing the gaps or the delays in treatment, which we have always and oftenly in Egypt and in low and middle income countries. Promoting the QA processes, and this is done mainly by the radiation oncologists through the paperwork or by the physicists. Thorough documentation and effective staff communication, which is the continuous professional development. So image-enabled geometric targeting and should end in a personalized radiotherapy by a high-quality radiation, by dose escalation. That's why we're using ultra-hypofractionation, SBRT, SRS. Toxicity reduction by minimizing the volume of radiation. Hypofractionation with its types. Voxelization by the planning system, and adaptation to adapt your treatment either on daily basis or weekly basis as far as your protocol of adaptation is fulfilled. So this is from the past, from 1960 first clinic to the 2020s, we are using functional imaging in delineation. So it's a 60 years development of radiation therapy. And we shifted from anatomy physiology to metabolism and molecular. We're using the PET scan, the diffusion weighted MRIs for better delineation of our volumes. The evolution of radiation with IGRT, you have a target improvement of 13% and a tumor control probability by 33% at 5 years and survival by increased by 10 years. This is IGRT in survival. What about ultra hypofractionation for the SRS and SBRT and the breast cancer nowadays? It is the notion started 2004, and in 10 years time it increased to 10%. I think now it's hitting a 20 to 25% ultra hypofractionation regimens because more and more experience is coming up. Medical physics plays from 60 to 70% of the workload, from the dose volume planning to the IGRT to the QA, virtual simulation, adaptation, correction. So thanks to them. This is one of the examples of the evolution of management of rectal cancer over 40 years, 14 trials, starting from TME only, and now we are watch and wait. So everything takes time. So evolution takes time. Start about speaking about Egypt, we have, according to our 2014 paper, we have the liver, breast, bladder, and non-Hodgkin lymphoma, lung, 5 main categories. We'll be showing some of these examples in the NICC. And because cancer is increasing, by 2050 will be tripled, so we should increase the patient acceptance, but with the limited resources, we have to think of other advanced techniques adopting ultra hypofractionation. So this is our NICC stats. Over 20 years, we are about 16,250 patients. This is in blocks every 5 years or 10 years. We started by 2,500 in the late 90s, and now in the 20s, we are 10,000 patients. So the classification of patients in 2020, it goes without saying, breast cancer number 1, palliative was 9%, and brain tumors, head and neck, pelvic tumors plays around 15%. And in 2022, the prostate cancer heightened up at 10%, and all the other percentages were the same. Apart from the palliative, we had a very low palliative patients. And in 2023, palliative patients increased again, and the head and neck increased by 3%, brain tumors dropped by 4%, and prostate cancer dropped by 5%. This is because of many other centers that is taking place or doing a very good job in prostate cancer IMRT. Very interesting to note that we implemented fast and fast forward for our breast cancer patients. 60 of them are fast and 40% are fast forward patients. Advanced techniques, 1,600 patients IMRT, 300 VMAT and DCAT 20, and 10 SRS and 10 SBRT. Very good with the challenges we have. We don't have a triple F, we don't have an image guidance ABC, we don't have tracking, but we have very good medical physicist team members. The 10 SRS cases were 2 oligometastatic from breast cancer, 8 with multiple brain metastases less than 3 METs lesions, and all of them were treated according to the volume. Whenever you have a volume of less than 2 centimeters, you can give an SRS of 20 gray. With more than 2 centimeters, you can give up to 18 gray. The SBRT cases were mainly 2 lung. We'll show them. One was done with the MIP, and the other was done with the DCAT, and 7 brain cases like an SRS, but giving fractionated, not single dose. Because Nasser Institute is called Nasser Institute for Research, so the medical physicist compartment or department did 20 scientific abstracts and papers. Thanks to them and thanks to our dear colleagues. These are some of the medical physics papers and abstracts. And the evolution, first 3D conformity therapy was done on the Anchor in 2009. First static IMRT was in February 2010. And the first case of a grid, which is a palliative, but we implemented in 2014. In dynamic IMRT, we started in December 2019 with the implementation of the new synergy. And first case of VMAT in February 2021. HyperArc VMAT in June 2021. And first SRS and SBRT went over since 2021. The challenge is the organ motion, the lung cancer mainly, and with the absence of gating system, we're using the MIP to estimate the variations in lung mass with the respiratory cycle, hence decreasing the PTV margin and avoiding high dose of the organ at risk, and we'll be showing one in the coming slides. The CT simulator is done in 3 phases, in the deep inspiration and deep expiration and the free breathing with the MIP estimation. And another challenge for the CNS focal SRS and SBRT cases We don't have a triple F facility, but we did it with a good coverage and sparing of the organs at risk. And very interesting to note, we treated 3 female pregnant patients. All of them were having brain gliomas, and one of them was coming on the 38th week, and one of them was coming on the 28th week. And by giving a 3D conformal, not an IMRT or a VMAT, without a vertical field, we achieved nearly a zero dose, because there is no zero dose, but nearly a zero dose to the fetus. And we were having one of these patients in a follow-up last month with a normal baby, but she refused to be photoed. So we respect her privacy. So this is to show you the 3 phases of the scanning of the MIP. See how the breast, there are 3 contours. So these are the 3 phases of the MIP. And then we do a registration. And after the registration, you can see nicely the difference. And this is all done by our physicists. I always thank them every day I go to NCI. Really, they are doing a very good job with the radiation therapists. They are really the key players. We only put the plan, but they are the key players on a daily basis. So the actual treatment volume is 5.2 because we did the MIP versus 4.7 if we do it on a single scan. So, and the patient was treated with the VMAT 56 in 8 fractions. We adopted the Dutch protocol 60 in 8, but we reduced it for the constraints of the rib, and we achieved the rib tolerance of a 30 cc less than 10 gray by following the RTOG protocol. This is again, the MIP. And we did the T4 breast cancer patient who failed 3 lines of chemotherapy and was feeling terribly bad, and she was coming with a skin fungation. So what we did is we did the 2 arc for the patient. With on the left hand side you see the very aggressive lesion with skin thickening and skin infiltration, and after treating her with a hypofractionated regimen 14-15 followed by a boost, this is on the right hand side, and she came with a no disease clinical CR and radiological CR, and she is living nicely. Next, we did an ISRT, of course, with a deep inspiration breath hold, sparing most of the heart in our lymphoma cases, especially for the superior mediastinum patients. And this is to show you the grid therapy, which was done also by our physicists, because we don't have the grid template, but we do have, did it by the MLC, and they published 2 or 3 papers about the grid therapy for a patient with a very big malignant peripheral nerve sheath tumor, which is irresectable, and he came again in a clinical CR after 1 year, and a limb soft tissue sarcoma with the neurovascular bundle infiltration that was candid for amputation, but we give him a 15 gray single fraction followed by 14-15, and patient is living nicely but with a non-functioning limb. And this is the DCAT, which was done for the portal vein thrombosis, a 40 gray in 8 fractions, and after 3 months the portal vein thrombus was gone. This is a DCAT for a T1 non-small cell lung cancer, and patient was having a double primary, Hodgkin lymphoma stage 4, and lung cancer. So because of the area and the patient was under chemotherapy, we gave him a radical radiation dose of 50, I think, in 8 fractions. Yes, and the patient is a T1 non-small cell lung cancer, and this was his PET scan 6 and 14 months after treatment, and he's under follow-up for the Hodgkin lymphoma. The prostate cancer localized with a VMAT, very nice dose distribution to the prostate, sparing the rectum, and the hyper-arc, which was published in 2019-20, we did it for a high-grade meningioma by giving a 58 gray only, able to deliver a D2CC to the brainstem, very low, 56. So this is the video of the high-grade meningioma with the hyper-arc, and this is again another, the same, but with a different video. And this is the combi MCT with the DIBH and without DIBH. It's evident that the green volume is spared by the DIBH versus the without DIBH. The fast and fast forward protocol. This is the first 2 weeks post radiotherapy, the fast, and 4 patients, the first and second and third and fourth week respectively. And recently, because we had a chair in the cancer center who is a pediatric oncologist, he asked us to start doing total marrow radiation. So we did very fast with our physicist dosimetric marrow plan, and we are going to improve this plan, of course, until we start to implement total marrow radiation in pediatric patients. This is interesting, again, a T4 male patient, 72 years old, with a skin invasion, irresectable, and we give him a fast protocol, but with a 6 gray by 5 fractions weekly, and 2 weeks after treatment, and 8 weeks after treatment. So my take-home message is that with advanced techniques, it enables us for more precise radiation, better treatment results, less toxicity, better quality of life. Thanks to the medical physics doing IGRT, QA, dosimetry, and integral team members, our medical physics team, Dr. Ahmed Musa, Dr. Asma, Nawal, Sarah, May, our radiotherapist, nurses, and workers. Thank you very much for your attention, and I hope it was useful. Any questions? So thank you very much.
Thanks, Dr. Ihab, for your beautiful talk. And our next speaker is Dr. Ahmed Yasser Abu Madian from the Department of Radiation Oncology, University of Medical Center Mannheim, University of Heidelberg, Germany. A dear friend and a colleague of mine for 40 years.
30 خليهم 30.
Thank you very much.
بسم الله الرحمن الرحيم. ياسر ابو مدين اساسا من القصر العيني، قسم علاج الاورام. استاذ الدكتور عماد حماده قاعد معانا النهارده، وانا سعيد ان انا شايفكم جميعا. في حد معانا هنا بيتكلمش عربي؟ Anybody speaking only English؟ انا بحب اتكلم بالعربي صراحه، معلش لو بعد اذنكم يعني. ما اقدرش اتكلم كويس زي الدكتور ايهاب كده في الانجليش بتاعه كويس كده، اما هقلب بالالماني ولا حاجه فتبقى العمليه غريبه شويه. طلب مني ان انا اتكلم على الستيريوتاكتيك بادي راديوثيرابي، خبرتنا في مانهايم في المستشفى الجامعي هناك. واحنا عندنا خبره كبيره من 2005 تقريبا، ستاندرد واي اوف تريتنج بيشنتس بالستيريوتاكتيك بادي راديوثيرابي. طبعا ابتدينا زي معظم السنترز ابتدينا باللنج، وبعد اتنقلنا من حاجه لحاجه بعد كده، وعندنا يعني في التكنولوجيكال اسبيكتس في اوبشنز موجوده عندنا مختلفه، فيعني هتكلم معاكم فيها النهارده. الكلام على الستيريوتاكتيك بادي راديوثيرابي اساسا حاليا في الفتره الحاليه بنتكلم طبعا مش باليشن زي زمان، بنتكلم على الاولجوميتاستاتيك بيشنتس، والديسكربشن بتاع الاولجوميتاستاسيس ابتدى يمكن من فتره طويله قوي، في يمكن هنا من 95. اتكلم على biological point of view ان it's a certain phase where you still have عندك فتره ما بين ان المرض يكون لسه limited disease وابتدى يبقى widely disseminated في فتره قصيره جدا، من ناحيه من biological point of view ان المرض يكون لسه فيها الديسيميشن بتاعه بطيء. لو احنا لحقنا في الفتره دي المرض نوقفه بلوكال تريتمنت طبعا جنب السيستميك تريتمنت، بيبقى في فرصه جيده جدا ان احنا يمكن نرجع ببعض المرضى تاني لستيتس اوف كيور او ستيتس اوف ديزيز فري ستيتس. الديفينيشن اوف اوليجوميتاسيس اتغير يمكن في ال10 سنين الاخرين بالذات كتير قوي. كنا بنتكلم في الاول على 1 سنجل ليجن او 2 ليجنز، وبعدين نتكلم في 3، وحاليا مقبول نتكلم على الاقل على 5 ليجنز disseminated ليجنز في الجسم كله. والستاديز الحاليه بتتكلم او بتحاول انها تنكلود بيشنتس لغايه 7 او لغايه 10 ليجنز. هل هنلاقي فيه بنفيت في علاج الحالات ديت ولا لا؟ لسه بندور يعني. الهدف زي ما قلنا الاساس ان احنا نحاول نوصل ببعض المرضى للبوتنشال كيور دوت. احنا بنتكلم دايما بوتنشال، ما حدش ضامن المريض فعلا هيخف ولا لا. او الهدف يمكن الاسهل او الاسهل ان احنا نوصل له في اغلب الحالات دي لونج تيرم ديزيز كنترول، بدل ما نبقى احنا شغالين كله بسيستميك تريتمنتس والتوكسيستي عماله تعلى معانا من لاين للاين. لو احنا قدرنا نحجم يمكن الميتاسيس ديت نقدر نوصل لريزلتس احسن. طبعا السيرجيكال ريموفال هو يمكن الطريقه الرئيسيه ان احنا ازاي نعالج اوليجوميتاسيس، لكن الفوكس راديشن او الستيريوتاكتيك بادي راديوثيرابي تو هاير دوزز او اذر ابليتيف ميثودز طبعا ليها دور كبير، يمكن ريبليسنج السيرجري في حالات كتير جدا. البيشنت سelection اساسا بنتكلم في طبعا لازم يكون مريض الحاله العامه بتاعته كويسه، فيري جود جنرال كونديشن ده هو الاساس، او على الاقل الكارنوفسكي اندكس بتاعه ما يقلش عن 70%، لان طبعا لو الحاله المريض العامه وصلت لمرحله انها تدهورت الاستفاده على المدى الطويل بتكون قصيره جدا. تاني حاجه لازم يكون عندي فرصه ان انا طالما هعالج الميتاسيس بطريقه ابليتيف لازم اقدر اوصل ان انا اكونترول البرايمري تيومر، ما اقدرش اسيبه. فده لازم يكون هدف موجود في البلان من الاول. انا بركز على البرايمري تيومر كنترول جنب التريتمنت اوف ديسيمينيشن او الميتاسيس. واخر حاجه طبعا السلكشن، يعني الليجن اللي هعالجه واديله هاي دوز راديشن لازم يكون قاعد في حته اقدر اديها ابليتيف دوز، بمعنى ما يكونش حجمها كبير جدا، وما تكونش اللوكيشن بتاعها very close او in contact او يمكن infiltrating organ at risk او structure ما اقدرش اتعامل معاه. بقيه التوكن هديكم مجرد اكزامبلز من حالات يعني اخترتها في وسط الكلينيكال روتين بتاعنا. الهيستوري بتاع الحالات يمكن انا بحاول اختصره شويه. الحاله دي كانت سوبرا جلوتيك لارنجيال كانسر، 53 سنه، فيرست دايجنوزس في 2014. ابتدى بالادجفنت تريتمنت او البرايمري تيومر تريتمنت كان سيرجري، والبوست اوبرتيف راديو كيموثيرابي كان ادفانس ستيج، وقعد معانا سنه ونص تقريبا لغايه 2016 ديزيز فري، وبعدين ابتدى يظهر ليجنز في اللنج. مع الشيست سي تي لقينا 4 مره واحده. كان اياميها لسه ما دخلناش في الايرا بتاعت الاميونوثيرابيوتكس بدرجه جامده، فكان الحاجه الوحيده المتاحه تاني كيموثيرابي سيسبلاتين 5 اف يو، وكان السيتوكسيماب افيلبل في الفتره دي وكان ليه ايفيدنس كافي، وكان محطوط في الفيرست لاين باليشن ككيموثيرابي فاللي هو الاكستريم ترايل. وابتدينا العلاج في الفتره دي. اي ثينك الحاله دي كانت خدت ما كملتش 6 سايكلز، خد يمكن 4 او 3 سايكلز. دخل في ريميشن كومبليت ريميشن لتو ليجنز، والاذر تو ليجنز كان فيهم بارشال ريميشن. وابتدينا نتابعه. قعدنا بعد المرحله ديت يمكن 3 اشهر كمان الوضع ثابت، وبعد ابتدى التو ليجنز اللي كانوا في بارشال ريميشن، يمكن الصوره اللي فوق على اليمين ديت فيها بروجريشن لوان اوف ذا مين ليجنز اللي هي اكبر واحده فيهم فعلا. بعد ما دخلت في بارشال ريميشن رجعت تكبر تاني. فابتدينا نتكلم على اللوكال مانجمنت. جراحيا كانت غير مقبول، الليجن ده يمكن كان كبير شويه بالنسبه للجراحين. التوكسيستي بتاعته عاليه، كان ممكن يؤدي ان تعمل نومونكتومي كامل في الاخر، لان كان ليه يمكن تيل صغير مش باين في الصوره هنا واصل لغايه الهايلم. فكان الكلام على الستيريوتاكتيك بادي راديو ثيرابي. احنا بنقسم الليجنز زي ما الدكتور ايهاب يمكن حتى وصف كده في الحاله اللي بينها. الليجن اكوردنج للسايد بتاعه برضه نقدر نعلي الدوز او نقلل الدوز عشان نحاول نحافظ على التوكسيستي بروفايل بتاعنا تو ا سيرتن ليميت. الليجنز القريبه يمكن من الهايلم او من الميدياستاينم بنقلل الجرعه شويه. التو ليجنز خدوا 60 جراي. الليجن الكبير اللي فيهم اللي في الرايت سايد 5 جراي بير فراكشن. الليجن الاصغر اللي موجود على الليفت موجود في الليفت لور لوب خد 12 جراي بير فراكشن. ده البروتوكولز بتاعتنا في الاساس، هوريكم التفاصيل يمكن في السلايدز الجايه. ده الريسبونس بتاع الحاله. الليجن الصغير اللي على الشمال في اللقطه اللي فوق مع الفولو اب بعد 10 اشهر وبعد 18 شهر، والصوره اللي في النص الليجن الاكبر هو كمان دخل في كومبليت ريميشن. كل اللي بقى التيبيكال فايبروز اللي بنشوفه بعد الراديو ثيرابي او الستيريوتاكتيك بادي راديو ثيرابي في الحالات دي. اكزامبل تاني برضو هنا النك كيس بيز اوف تانج 50 سنه 2013 فيرست دايجنوزز. اتعمل برضو الكلاسيك تريتمنت تيومر ريسكشن نيك ديسكشن. الحاله دي خدت انترا اوبرتيف راديو ثيرابي. كنا في المرحله دي عندنا كلينيكال ترايل لانترا اوبرتيف راديو ثيرابي لحالات الهيد النك، فخد 8 جراي لوكال على التيومر. بوست اوبرتيف راديو كيموثيرابي لغايه 66 جراي كومبايند مع سيسبلاتين 5 اف يو. كلاسيك سيناريو في الفتره دي في 2013. تاني ما عدناش سنه ونص ظهر عنده 3 لانج ميتاسيسز. هنا اكزامبل لواحده منهم بس، هما كانت واحده على الشمال واثنين على اليمين، ودخلنا عليهم هم الثلاثه كانوا فيري ويل لوكالايزد، مش قريبين من الاورجنز ريسك في وسط اللنج. ده بيسهل جدا ان احنا نعلي الجرعه. الثلاثه خدوا 60 جراي على 12 جراي بير فراكشن، ولغايه اخر فولو اب بعدها ب6 سنين لغايه سنه 2020 نو ايفيدنس اوف ديزيز. دي الحالات اللي احنا بنتكلم فيها ان احنا ممكن نقلب حاله ميتاستاتيك اوليجو ميتاستاتيك نرجعها تاني من غير سيستميك تريتمنت لعند ما خدش كيموثيرابي خالص بعد اللي يمكن الادجفنت فيز بتاعته ما خدش حاجه بعد كده وفضل ديزيز فري الفتره دي كلها. دي الداتا اللي احنا جمعناها، يعني كانت في محاوله ان احنا نجمع داتا اكتر شويه الفتره الجايه من 2013 ل 2018 حالات الهيد النك بس، مش يعني احنا طبعا بنعالج اي ميتاستاتيك ديزيز من اي برايمري، بس دي حالات الهيد النك بس اللي عالجناها في الفتره ديت الخمس سنين دولت. عندنا 8 عيانين ب 17 ليجن كلهم خدوا ستيريوتاكتيك بادي راديو ثيرابي. بيتكلم عن لانج ميتاسيس فقط، ما اتكلمش على بون او برين او اي حاجه ثانيه. كلهم دخلوا في يا اما في كومبليت ريميشن يا بارشل ريميشن يا ستيبل ديزيز، حالتين ستيبل وحاله بارشل، والباقي كله لوكالي دخلوا في كومبليت ريميشن. يعني عندي لوكال كنترول 100%. لما نبص على الثمان حالات في الجدول الثاني الصغير اللي على اليمين دوت هنلاقي ان الثمان حالات في منهم اربعه اللي هم متعلمين بالاخضر دولت فضلوا ديزيز فري لغايه اخر فولو اب. الفولو اب بتاعهم ما بين سنه ونص لغايه 5 سنين فولو اب. يعني تقريبا عندي 50% من الحالات نقدر نظريا نقول احنا كاونكولوجي صعب قوي نقول كلمه كيور، بس قدرنا ندخل عين في فيري لونج تيرم ديزيز فري بيريد. طبعا الاربع حالات التانيين يعني اربعه ظهر عندهم اذر ميتاسيس في ليجنز غير اللي احنا عالجناها. فعندي لو 100% لوكال كنترول، بس طبعا كالمعتاد دايما لازم في حالات بتفلت منا، عدت المرحله اللي هي البيولوجيكال interim phase where you can still salvage your patient. الكومباريزن دي برضو ما بين الجراحه والراديو ثيرابي او الابليتيف راديو ثيرابي موجوده في كذا ترايل. ده وان اكزامبل هنا، ان هل كل العيانين لازم يروحوا يعملوا ريسكشن ميتاستاتكتومي ولا ممكن اعالج بالراديشن فقط؟ في داتا موجوده من كذا بابليكيشن كلهم بيصبوا في نفس الحته، ان اللوكال ريزلتس على الاقل ذا سيم. بس طبعا السلكشن اوف بيشنت في حالات فعلا انا كراديشن اونكولوجيست لازم اقول للجراح لا اتفضل اشتغلها انت، انا ما اقدرش اقرب منها. لو الليجن موجود في certain regions ما اقدرش انا اعالجها بهايلي ابليتيف دوزز. النقطه الثانيه ان وات ايفر وير تريتنج الداتا دي من عندنا من مانهايم برضو، وبارشلي يعني ان هي كانت كومبايند داتا جايه من سنترال يوروب، احنا كونتريبيوتد ليها. سواء البرايمري لانج كانسر طبعا ايرلي ستيج 1 او ميتاستاتيك ليجنز في اللنج. الديسايزف فاكتور هنا مش الهيستولوجي. بالنسبه لنا احنا كراديشن اونكولوجي انا مش فارق معايا هو ده سكويمس سيل ولا ادينوكارسينوما ولا اي حاجه ثانيه، وما بقعدش ابص على الماركرز ولا الحاجات دي، مرميها ورا ظهري. بص على حجم الليجن واللوكيشن، اقدر اديله ابليتيف دوز ولا لا. والهدف بتاعي هنا ان انا اعلي البي اي دي بيولوجيكال افكتيف دوز. لما بصينا على الداتا بتاعتنا احنا في مانهايم، والببليكيشن دي برده من 2014، لقينا ان الكات اوف بتاعتنا اراوند بي اي دي 80. يعني لو وصلت البي اي دي بتاعي فوق ال 80 جراي، اللوكال كنترول عندي، وده الكيرف في الجزء هنا نمبر دي في الفيجر، الكيرف الفوقاني دي الحالات اللي خدت فوق 80 جراي بيولوجيكال افكتيف دوز. الحالات اللي خدت اقل من بي اي دي 80 اللوكال كنترول بتاعهم كان اقل، يعني نزلنا من حاجه و90% لحوالي يمكن 78%. وده الهدف بتاعنا دايما irrespective اللوكيشن والسايز. لو انا قادر، وده اللي احنا بنعمله في التيومر بوردز، واحنا قاعدين الدسكشن بيحصل، ميديكال اونكولوجيست عايز يدي الاميون ثيرابي ما اعرفش ايه، والسيرجن عايز يدخل يشيل التيومر، وانا قاعد بلقط الحالات اللي انا اقدر اديها البي اي دي 80 او اباف. لو قدرت القط دولت بوفر على العيان ان هو يمكن يدخل في سكند لاين كيمو لو ده اوليكو بروجريس مثلا ولا حاجه، او اوفر عليه جراحه يمكن المريض يمكن يكونش محتاجها. الليجنز الاصعب بالنسبه لي بقدمها على طبق من ذهب يمكن لايه، للزميل في التخصص الاخر. التوكسيستي بروفايل قليل، الداتا دي برضو من عندنا، اول 43 حاله لانج يمكن عملناهم. ما فيش فرق ما بين البري تريتمنت للاكيوت للكرونيك فيز فولو اب بالنسبه للديسنيا والكاف. الداتا بتاعتنا في الاول كانت يعني فيري بروميسنج، كنا متشجعين ان احنا نستمر بالدوز بروتوكول بتاعنا. طبعا بعد كده في داتا كتير قوي توفرت بعد كده، كواليتي اوف لايف، فيز 2 ترايلز، فيز 3 ترايلز، كلها زي ما انتم شايفين الفلات كيرفز اللي تحت دي، سواء الهيموبتسيس او الكافينج او الديسنيا او كواليتي اوف لايف هيلث ستيتس جلوبال هيلث ستيتس. المرضى بيدخلوا ياخدوا الجلسات بتاعتهم وبيخرجوا من الناحيه الثانيه وبيكملوا فولو اب، وبنشوف فعلا فيري فيري لو توكسيستي ريتس. بمعنى ان احنا طالما محافظين على الدوز بروتوكول السليم للعلاج بتاعنا ما بنشوفش فعلا كومبليكيشنز عنيفه. ومع ذلك كومن اكزامبل، لو انا عايز ادي ابليتيف دوز والليجن هو يمكن اكشلي في الصوره اللي في النص فوق هنا الليجن مش واصل للريبس، البي تي في مارجنز بتاعتي كانت جينيرس شويه، فالبي تي في عمل اوفرلاب مع الريبس، وبعدين الراديشن فيزيست لما عمل البلان ما عملوش كونفورمال بالدرجه الكافيه. فندخل هنا في ايه؟ ان عندي دوز بيلج اوتسايد تارجت بجرعات عاليه، والحاله دي خدت ال 60 جراي على 12 جراي بير فراكشن 5 جلسات. كونسيكونسز كالس وفراكشر دريب وراديو نيكروزز تيبيكال بتحصل كتير. لو انا شايف ان هخفف المريض او في فرصه، يعني اوليجو ميتاسيس فعلا والمريض ده عنده فرصه انه يخف، بجيبه الاول واقول له انت الليجن بتاعك قريب من الريبس ديسبوزبل اورجن بالنسبه لنا، يعني مش هيجي له سيفير بين. الحالات اللي احنا شفنا يمكن 7 8 حالات اوفر ثرو ذا ييرز بالمنظر ده، ما حصل لهمش كومبليكيشنز عنيفه جدا، البين ما كانش جامد لهذه الدرجه، كنترولد مع انالجيسكس خفيفه، والبين بيبقى اون اند اوف مش كونتينيوس. هو الشكوى اللي دايما كونتينيوس في المرضى دول لو هي في الجنب فعلا المريض يقول لك انا مش عارف انام على الجنب ده، ودي برضه ملحوظه لازم ابقى انا حاططها في قصاد عيني وانا باخد القرار، هديله جرعات عاليه ولا اخفف عليه المشاكل شويه واخد الريسك ان الكنترول يمكن ما يوصلش للدرجه اللي انا متوقعها. بس يمكن دي مش مشكلتنا الرئيسيه، مشكلتنا الرئيسيه المشاكل الثانيه اللي موجوده هنا دي دول الليميتنج فاكتورز بالنسبه لي. لو انا بتكلم في اسبرتي في اللنج، لو عندي سنترال او الاسوأ الالترا سنترال لانج ليجنز، دولت اللي انا ما اقدرش اعلي الجرعه فيهم، اوصفهم بالتفصيل دلوقتي. الانترستيشال لانج ديزيز مريض جاي اللانج بتاعته وحشه اصلا، او خد راديشن على الميديستاينم قبل كده، او عنده مالتيبل ليجنز. طبعا يعني لغايه 3 ليجنز سيمالتينيوسلي عملنا كتير. لما بيدخلوا في 4 سيمالتينيوس بنبقى مقلقين مش عارفين هتنفع ولا لا. لكن لو سيكونشال عملنا 3 النهارده وبعديها بسنه ولا حاجه المريض جاب 2 ليجنز كمان. عملنا حالات بالمنظر ده قبل كده ان احنا وصلنا ل5 ليجنز في اللنج و6 ليجنز في اللنج لو سيكونشال مش كلهم جايين في نفس الوقت. يعني في جاب ما بين العلاج الاولاني والثاني. وطبعا السيناريو الاشهر لما حد يبعت لك حاله يقول لك عايزين محتاجين هنا اس بي ار تي واللنج تيومر قد كده او الميتاستاز كبيره جدا وانفلتريتنج. دي بتبقى طبعا الكومبليكيشن ريتس ممكن توصل جريد 3 اب تو 5 جريد توكسيستي ممكن توصل لغايه 30% ودي ارقام مرعبه طبعا جدا. المرعب اكتر الداتا من الاناليسيس دي ويمكن الصوره دي من اهم الصور بالنسبه لنا. 3 فراكشن تريتمنت لغايه 60 جراي اب تو 66 جراي. الجريد 3 بلس توكسيستي كانت عاليه زي ما مكتوب هنا من 10 ل 27% للسنترال او البريفرال ليجنز. الفرق طبعا في السنترال ليجنز اعلى كتير. الاسوأ الخمسه ديسز من 70 عيان حوالي 7% of the patient يمكن او اكتر ماتوا جريد 5 توكسيستي بسبب الاس بي ار تي. الحمد لله ما شفناش الكلام ده مش عندنا في منهج يعني بس يؤدي لملاحظه مهمه جدا. الرسمه اللي موجوده هنا دي النقط المخططه بالاسود دي يمكن اهم حاجه بالنسبه لنا دي بنسميها النو فلاي زون بالنسبه لنا. لو الليجن قريب من الميدياستاينم كلوزد للمين برونكس او للتراكيه للاسوفاجس او للجريت فيسلز دي الالترا سنترال ريجنز دي جرعاتهم لازم بتقل جامد جدا والا هتدخل في مشاكل. لو بعيد عن الاورجنز ديت مش ان كونتاكت معاهم بس وزين ال 2 سنتيمتر من المين برونكس اللي هي المنطقه اللي بالاسود بقى مش اللي بالاحمر دي ممكن ندي جرعات متوسطه يعني اقدر اعلي الجرعه بس برضه لازم اخد حذري شويه. ده البروتوكول بتاعنا في مانهايم واحنا بنمشي بطريقه سيمبل جدا ما عندناش سوفيستيكيتد فيكسيشن تكنيكس وما عندناش اي حاجه معقده. المريض بيطلع على الترابيزه وينام فقط لا غير ما بيعملش اي حاجه تاني. اوريكم صوره ولا اتنين دلوقتي. كل الحاجه الوحيده اللي بنطلبها من المريض انه يعمل ديب انسبريشن بريث هولد. وعندنا مونيتورنج سيستم للديب انسبريشن دو سيستمز. المارجنز بتاعتنا مش جنرس قوي يعني بنتكلم في 2 ملم من الجي تي في للسي تي في حط عليهم 3 مللي للبي تي في. كرينيو كودل بنزود شويه تقريبا بناخد 8 كمان ترسي على 10 مللي يمكن كرينيو كودل من الجي تي في للبي تي في مره واحده. التقسيمه بتاعتنا زي ما موصوفه هنا بتدي من فوق البريفرال ليجنز اللي مش ان كونتاكت اللي مش لازقه لا في الريبس ولا في الميدياستاينم بندي اعلى جرعه 5 فراكشنز 60 جراي بريسكرايبد على 95% من الفوليوم وبنزود الدي ماكس يعني الانسايد الجي تي في الدي ماكس بتاعنا بيوصل لغايه 150% يعني براكتيكلي لغايه 90 جراي والجرعه بتتاخد كل تاني يوم. الحالات اللي فيها اوفرلاب مع الريبس زي ما قلنا الريبس احيانا بنحاول نحافظ شويه على المشاكل بتاعتها نقللها فبنقلل الجرعه من 12 جراي بير فراكشن ل 5 جراي بير فراكشن والتريتمنت هنا بيبقى ديلي يعني 12 جلسه يعني بدل 5 جلسات بدي 12 جلسه بوصل ل 60 جراي برضه وبقلل الدي ماكس بتاعي شويه. وهنا في فاريابيليتي شويه يعني ممكن العب على 110% او ممكن ازودها يمكن ل 125% في بعض الحالات حسب الاوفرلاب مع الريبس كبير ولا صغير. الحاجات الاخطر شويه اللي هي السنترال ليجنز اللي هي في المنطقه اللي متعلمه بالاسود ديت دي بنقلل الجرعه برضه ل 60 جراي 5 جراي بير فراكشن بنفس البريسكربشن ل 110 دي ماكس الماكسيمم بتاعي. الالترا سنترال ليجن زي ما قلنا اسوفاجس جريت فيسلز مين برونكس او التراكيه لازم ننزل بالجرعه تكه كمان لتحت ودي هنا بنبتدي ندخل في بي اي ديز اقل من 80 نبتدي ندخل في لوكال كنترول اقل كتير جدا ولازم هنا اعمل تريد اوف. يعني لو عندي اذر اوبشن سيرجيكال او اي حاجه ثانيه او اتكلم مع حد في الميديكال اونكولوجي طب انتوا لسه عندكم فرصه تدوا حاجه ثانيه يمكن التيومر يصغر يمكن لما يصغر يبعد شويه عن الاورجن الفلاني يمكن اقدر اعلي الجرعه بعد كده. او لجأنا في الاربع سنين الاخرانيين لسه ما عندناش داتا منهم ان احنا بدل ما ندي 35 جراي على 5 جراي بير فراكشن ان احنا ندي 20 فراكشنز 2.75 اللي هي 55 جراي ونشوف اللوكال كنترول مع الجرعات دي مور اور ليس يعتبر يعني ايه مينيمال هايبوفراكشنيشن مش كلاسيك ستيريوتاكتيك راديو ثيرابي بس التكنيك واحد برضه دي بانسبريشن بريث هولد يوميا وايمج جايدنس يوميا للعلاج. الموشن مانجمنت عندنا في مانهايم احنا زي ما قلت بنشتغل بيورلي على الديب انسبريشن بريث هولد والحالات اللي طب المريض اللي ما بيقدرش يعمل ديب انسبريشن بريث هولد لاسباب مختلفه مش قادر يحبس نفسه اللانج فانكشنز وحشه عنده مشاكل او مش فاهم التكنولوجي يعني بيبقى فيه طبعا لازم المريض يفهم هو بيعمل ايه معانا يعني. بنشتغل على 4 دي سي تي اللي هو الاي تي في فوليوم وذ مارجن. الديب انسبريشن بريث هولد عندنا السي راد الكاتاليست من سي راد ده الاوبتيكال سكاننج سيرفيس سكانر بتاع البادي بيساعدنا في السيت اب بتاع البيشنت وبيساعدنا كمان ان احنا نمونيتور الموفمنت بريدنج موفمنت. وعندنا الاي بي سي ده بيعتمد على الفوليومتري المريض بيتنفس عن طريق خرطوم بتوصل بجهاز قياس للفوليوم اوف اير اللي داخل واللي خارج، وبيقيس لنا الحركه او الفوليوم اللي بيتحرك جوه اللنج داخل وخارج. التكنيك سهل جدا، بلاننج سي تي ان ديب انسبيريشن بريث هولد. يبقى المريض الاول بياخد ديب بريث وهو بيتصور، والاجهزه شغاله، يعني الاي بي سي شغال او الكاتاليست شغال اثناء السكاننج. ما بنعملش اي زي ما قلنا اي فيكسيشن للمريض، ما عندناش فاكيوم اي حاجه بنعملها، ولا ابدومينال بريشر ولا اي حاجه خالص. المريض قاعد مستريح، مشبك في مناخيره وخرطوم في بقه وتنفس من خلاله. اهم حاجه ما يتنفسش جنب الخرطوم والا هيبوظ الدنيا كلها. البلاننج سنجل فيس، ما بناخدش طبعا مالتيبل ايمجز في الحالات الا اذا كانت الحاله هتشتغل 4 دي. والكونتورنج سيمبل جدا، اي ام ار تي، ايمج جايدنس ديلي مع التريتمنت عن طريق الكوم بيم سي تي اثناء البريث هولد. فيبقى برضو اثناء الاكوايرمنت بتاع الكوم بيم سي تي لازم المريض يكون واخد بريث هولد. عاده المريض معظم المرضى بيقدروا على 20 ثانيه. المريض اللي تعبان شويه بياخد 15 ثانيه بريث هولد. يعني الكوم بيم سي تي الدقيقه اللي بيحتاجها، احنا بنحتاج دقيقه واحده في الفول روتيشن كوم بيم سي تي تاخد على 3 بريزنج سايكلز. يعني لما يحبس نفسه 20 ثانيه ويريح 20 ثانيه وبعدين يحبس 20 ثانيه، هي بدل ما بناخدها في الدقيقه التصويره بناخدها في دقيقتين. ده ديلي للايمج جايدنس. والتريتمنت بعد كده خلاص، وانس عملنا الماتشنج، التريتمنت بعد كده بيمشي بنفس السيكونس برضه، بريث هولدز ومونيتورنج البريث هولد وصل للليفل بتاعه ولا لا عن طريق الاجهزه اللي معانا. وعندنا الاف اف اف والمالتي ليف كوليميتر في الاجهزه. احنا عندنا الاجهزه اللي موجوده الكتا حاليا. المالتي ليف كوليميتر سريع في الاجيليتيز عن السينرجي، في فرق كبير في الدليفري تايم بناء على الاف اف اف طبعا في الاساس والام ال سي. البراكتيكلي سبيكينج ال 12 جراي مع الاف اف اف على المكنه الاجيليتي بتاخد التايم سلوت بالايمج جايدنس بكل الهيصه اللي احنا وصفناها دي ما بتاخدش اكتر من ربع ساعه. يعني المريض بيدخل وبيخرج في تايم سلوت زي ما يكون عالجت انتروبوستيرور فيلد لحاله بون ما اعرفش في الفيمر ولا وات ايفر، اي حاجه بسيطه من اللي كنا بنعملها زمان يعني. ده المنظر مع الاي بي سي، جهاز بسيط خالص اللي مرسوم يمكن في الصوره اللي في النص دي على الترابيزه اللي بعجل دي، وجنبه ده بيتحط على الكونسول بتاع الفني التريجر سيستم بتاع المكنه. لما المريض بياخد نفسه الكيرف باين يمكن في الشاشه الصغيره اللي جنب المريض هناك دوت، بتبقى في واحده منها موجوده عند الكونسول، والكيرف بتاع البريدنج باين اول ما يوصل في الحته الخضراء دي. وده طبعا بيبقى المريض بيجي له اوردر بالميكروفون وهو نايم جوه على الترابيزه. ابتدي ياخد بريث هولد، ياخد البريث هولد، اول ما يطلع الحته الخضراء دي المكنه اوتوماتيكلي تقوم باديه البيم اون، ونبتدي نمشي مع المريض حسب هو سرعته حسب هو قدرته. في مريض ياخد الجلسه بالراحه خالص ما يقدرش يريح بسرعه، وفي مريض تاني بيريح بسرعه. طبعا الفرق في البلان كواليتي مع البريث هولد او without البريث هولد بيبقى سيجنيفيكانت في حالات كتير جدا حسب حجم الليجن او عدد الليجنز اللي بنعالجها في نفس الوقت. الببليكيشنز اللي مكتوبه دي كلها من عندنا على فكره، لو حد انترستد يبص عليها. ده الجهاز الثاني الكاتاليست بتاع سيراد سيرفيس سكانر، هدفه الاساسي البيشنت بوزيشننج اكشلي، مش المونيتورنج اوف بريدنج بس. هو ظريف جدا انه بيعمل نفس الايفكت في الاخر. النقطه الزرقاء والنقطه الحمراء اللي في الرسمه اللي تحت دي نقطه احنا بنحدد مكانها، بنحطها دايما على الابر موست ابدومن تقريبا عند الزيفويد بروسس كده. ومع البريث هولد بتاع المريض الجهاز بيقرا الديستنت تشينج وبيقدر يطلعها لنا على شكل كيرف زي في الصوره اللي تحت ديت. وفي الاخر نفس السيكونس بالظبط. المريض دايما سواء في الجهاز ده او الجهاز ده عنده فيجوال ايد، هو نفسه يقدر يشوف هو بيتنفس فين عشان ما يبقاش بيتنفس عمياني كده، ممكن يتنفس زياده عن اللزوم. فعندي ابر كات اوف وعندي لور كات اوف، يعني لو ما طلعش فوق ليفل معين المكنه مش هتبتدي، لو طلع فوق الليفل المطلوب برضو المكنه بتقف، او احيانا كتير بنشتغل مانيوال. يعني مش لازم يعني الفني اللي قاعد بره قاعد متابع الكيرف وبيستارت ويستوب في الوقت المناسب. انا مش هطول في الحاجات التانية كتير عشان عارف في سيشن في حد هيتكلم ليفر بس دي حاله اوليجو بروجرس، كان برضو هيد نيك كانسر. خد البرايمري تريتمنت بتاعه ادجوفنت تريتمنت، ابتدينا في 2014. ليتر اون برضو نفس القصه في نفس الفتره، سيتوكسيماب 5 فيو مع اكستريم بروتوكول عشان ظهر عنده، ده كان ديسيمينيت ما كانش اوليجو ميتاسيس، كان في اكتر يمكن من 10 ليجنز. اثنين منهم كانوا في الليفر والباقي في اللنج وفي البون. ولما خد الكيموثيرابي مع الاميونوثيرابي مع السيتوكسيماب دخل برضه في ستيبل ديزيز، كل ليجن صغرت او اتليست كانت ستيبل. وجينا في مرحله مع الفولو اب بعديها بحوالي يمكن كام شهر ابتدى يظهر بروجرس في وان اوف ذا ليفر ليجنز، فكان النقاش في التيومر بورد نسيبها ونشوف البروجرس هيوصل فين ونبتدي نشوف انذر لاين. بس في الفتره دي ما كانش في انذر لاين اوف كيموثيرابي، يعني باليتيف باكليتاكسيل ولا ميسوتريكسيت ولا حاجه زي كده اللي كانت افيلبل. فكان الكلام طب خلاص ما دام وان ليجن بس اللي ابتدى يكبر تاني ندخل عليه بالستيريوتاكتيك بادي راديو ثيرابي، وده اللي احنا عملناه. خد 5 فراكشنز لغايه 60 جراي. الليجن اللي في الصوره هنا تحت اون ذا رايت لوب. الليجن الثاني باين اكشلي في اللقطه اللي فوقيها هنا فوق، كان صغير لسه للاسف بعد ما خلصنا العلاج، وده فيري كومن بروبلم في الحالات دي. الحالات الاوليجو بروجرس اصعب كتير قوي من الاوليجو ميتاستاتيك ديزيز اللي هي برايمري دايجنوزد از اوليجو ميتاستاتيك. غالبا في المرحله دي البيولوجي اتغير خلاص، المرض اوريدي انتشر، المايكرو انفايرمنت بتاعت الميتاستاسيس اتغيرت تماما. الحالات دي بتبقى اصعب كتير جدا في الكنترول، فعشان كده this is still experimental. طبعا الليجن اللي عالجناه اللوكال كنترول بتاعه كان كويس، الليجن الثاني ابتدى يكبر وطبعا ما كانش فيه فرصه للعلاج زي ما باين في الصور اللي على اليمين هنا. الليجن الثاني هو اللي ابتدى يكبر معانا بعد كده. بس الهدف من السلايد ده ان انا اوريكم التكنيك بتاعنا برضو نفس الدوز بريسكريبشن تقريبا بتاعت اللنج، 60 جراي 12 جراي بير فراكشن، 5 جلسات كل ثاني يوم. او للحالات او الليجنز الاكبر حجما او اوفرلابنج مع الريبس، او الاصعب بقى هنا برضو النو فلاي زون بتاعت الليفر هي السنترال هيباتوبيليري ستراكشرز جنب البورتا هيباتس وال2 سم ونص انسايد ذا ليفر من البورتا هيباتس وانت داخل. المنطقه دي فعلا برضو ممكن ندخل العين في ليفر فيلير لو ادينا فيها هاي دوزز، فلازم نقلل الجرعه. وهنا برضو نفس السيكونس بتاعنا بالظبط، 60 جراي 12 او 6 جراي 5 جراي، او بننزل ل 35 جراي، وهنا بنلعب ما بين 5 جراي بير فراكشن او 7 جراي بير فراكشن. وبنحاول لو انا مش قادر اعلي الجرعه جنرالي حوالين التيومر كلها، ان انا على الاقل ازود الدي ماكس بتاعي. يبقى البريفرال دوز هي 35 وانا عندي في النص مثلا واصل لغايه يمكن لغايه 50 55 على 5 فراكشنز. دي بتحسن اللوكال كنترول وبتقلل لي الدوز البريفري اللي هي غالبا الاورجن ريسك، لو هو اورجن ريسك نوت اوفرلابنج. بس لو اوفرلابنج خلاص اسقط في ايدينا وما يبقاش في حل غير ان انا لازم اقلل الجرعه توتالي. الحاجه الوحيده يمكن هي تكنيكال اللي زياده عن اللنج، لان هو نفس السيكونس بالظبط برضه التصوير والكلام ده، ان احنا عندنا الترا ساوند سيستم بس ده اكسبيرمنتال مش موجود في الماركت للاسف حاليا، مش موجود. كان زمان في واحد اقدم منه موجود كوميرشال، ده احنا شارينه مش شارينه يعني بنعمل عليه ريسيرش من الكتا بروتوتايب، ان احنا بنمونيتور الموشن بتاع الليفر ميتاسيس زي ما باين في الصوره اللي فوق ديت الالترا ساوند ايمج. الصوره اللي في النص وي كان تراك الليجن. فيرست وي هاف تو ايدنتيفاي، يعني ان انا اشوف الليجن اصلا الالترا ساوند البروب لازق اهو في الجسم العين. انا معلش مش لاقي بوينتر هنا مش عارف ده شغال ولا لا. الالترا ساوند بروب ليه دراع فلكسبل، نحاول نحطه على جسم العين في المنطقه اللي اقدر اسكان فيها الليجن، وفي نفس الوقت ما يبقاش انسايد راديشن فيلد. الدراع ده لانه مليان معدن طبعا، وما يبقاش انسايد الكوم بيم سي تي ايمج بتاعي. بكوريجستر الكوم بيم سي تي مع البلاننج سي تي كلاسيك ايمج جايدنس عن طريق الكوم بيم سي تي، وعندي فوقيه الالترا ساوند بروب دوت كونكتد طبعا لانفراريد كاميراز في السقف بتاع الاوضه، ان هو ستيريو تاكتيك الترا ساوند ديفايس بيبقى عارف الليجن فين، وبيعمل اوفرلاي ما بين الصور بتاعه البلاننج سي تي بالماوس. ممكن والله فكره ما خطرش في بالي الماوس ده. شكرا. ده البروب اهو. فاقدر اكومباين الايمجز بتاعت البلاننج مع الكوم بيم سي تي اللي هي الصور الخضراء والبنفسجي اللي احنا متعودين عليها من الكتا ديت، وبيجي لي الصوره بتاعت الالترا ساوند ليها سيستم منفصل سوفت وير وهاردوير كمبيوتر لوحده كده قاعد على جنب بيوفرلاي برضه الصور. وانس ان انا التيومر ان ذا كوريكت بوزيشن بقدر اشوف الاوفرلاي بتاعه، وبرضه اقدر اعمل ماتشنج واقدر اعمل كوركشن للتيبل بوزيشن بحيث ان انا اتاكد ان الاي سنتر بتاعي في النقطه الصح جوه الالترا ساوند ايمج مش بس السي تي ايمج. لان كلنا عارفين في الليفر بالذات السي تي ايمجنج سواء البلاننج سي تي او الكوم بيم سي تي صورهم ضعيفه جدا، ما بنشوفش الليجنز اصلا. احنا اكشلي بنماتش الليفر كله على بعضه وبنماتش الدايفرام يمكن وشويه ريبس، لكن انا مش شايف الليجن نفسه. الالترا ساوند هنا ميزته رهيبه جدا جدا جدا، بس للاسف البروتوتايب ده شكله مش هينزل الماركت من الكتا على الاقل. كان زمان عندنا من نوموس جهاز تاني بيعمل نفس الحركه دي، بس للاسف برضه طلع بره الماركت مش موجود حاليا ما بيتباعش. اخر اكزامبل ولا قبل الاخير لو حسب الوقت المتاح يعني، حاله مالتيبل ميتاستاتيك لانج كانسر. وانا معلش هنافس الناس بتوع الجاما نايف عندنا هنا في مصر، انا وعدتكم هي حاله واحده. جاي برايمرلي بمالتيبل برين ليجنز، والمريض كان 80 سنه ومش عارفين اصلا حد هيعرف يقرب له ولا لا يعني باي حاجه خالص يعني، بس كان فيري فيت. المريض كان داخل على رجله وبيتكلم وبيتناقش وما عندوش اي كوجنيتيف ديفيسيت وما عندوش حتى اي سيمبتومز نيورولوجيكال سيمبتومز ولا حتى انتراكرينال تنشن ولا هيدك ولا اي حاجه خالص. والبرايمري تيومر ما كانش صغير. كان نقاش عنيف جدا، طب هو البرين راديشن خلاص يعني الموضوع خلصان يعني ما فيهوش مش محتاجه نقاش كتير، بس هو يمكن عشان الفتنس الرهيبه اللي هو كان فيها رغم ان عنده 80 سنه كان بيولوجيكلي فعلا المريض ده كان نديله بالكتير 62 سنه مثلا. فسحبناه على الجاما نايف، ركبنا الفريم. طبعا ليجنز لما بتكون كتير قوي كده لازم اركب الفريم، وعالجنا ال 10 ليجنز سيمالتينيسلي. البريسكريبشن بتاعهم كان 22 جراي، وما بين 50 ل يمكن 65% ايزوز لاين. ده برضو الكلاسيك، احنا بنحاول نوصل الليجنز كلها ل 22 جراي سنجل شوت لو هندي سنجل فراكشن. بقيه القصه يمكن مش انترستنج قوي. هو خد الاميون ثيرابي بتاعه، فضل لمرحله ستيبل. البرين هي الانترستنج بارت، ان هو فضل لغايه ما ابتدى يحصل بروجريشن في اللنج، وخد باليتيف راديشن اللنج والكلام ده كله لغايه 2018. يعني احنا عالجناه في 2016 لغايه 2018. البرين فضل برين فري، تيومر فري. عالجنا ال 10، وده اكسبشن طبعا، يعني ما بقولش ان حالاتنا كلها تمشي كده، بس احنا كان عندنا استعداد ان احنا عالجنا ال 10، ولو ظهر في خلال اثناء اللنج كانسر تريتمنت بعد كده ظهر ليجن تاني او 3 تانيين او 4 تانيين، طالما لقطناهم بدري وصغيرين ادخل على الاثنين اللي بعديهم، وبعدين ادخل على الثلاثه اللي بعديهم، وده السيكونس المعتاد عندنا. الجديد اللي حصل ان احنا الجاما نايف عملنا الابجريد بتاعه، الجاما نايف ايكون، وبقى عندنا الماسك سيستم. والماسك سيستم بيريبليس المسامير والهيصه دي كلها، لبعض المرضى بتبقى مش ظريفه. يعني ميزتها بالنسبه لنا يمكن الكومفورت بتاع العيان، بس الميزه الرئيسيه ان انا اقدر افراكشنيت التريتمنت. وده البروتوكول بتاعنا للميتاسيس في البرين ليجن على الجاما نايف، ان انا عندي الاوبشن اللي موجود عندي الماوس المره دي، عندي الاوبشن هنا ان انا افراكشنيت اللارجر تيومرز. يعني بيكون عندي ميتاسيس كبيره، احنا دايما بننزل بالجرعه اكوردنج لستاندز، بننزل ل 22، لو التيومر كبر شويه بنزل ل 20، وممكن انزل ل 18. بطلنا نعمل حكايه 18 دي لان الكنترول ريت بتاعها قليل قوي، يعني لوكال كنترول وحش مع 18 جري. الاساس السبب ان احنا بننزل 18 ليجن يكون كبير. فعملنا ريبليسمنت للكلام ده اوفر ذا ييرز. بقينا بندي 3 فراكشنز اوف 9 جراي، يعني 27 جراي على 3 فراكشنز. الريزلتس ما اقدرش احلف ان انا ما عملتش اناليسيس داتا لسه، بس ات لوكس بروميسنج. وشايفين اساسا السايد افكتس اقل كمان، الراديو نيكروزز في البرين قلت مع الفراكشنيشن، ودي موجود فيها بابليكيشنز يمكن كتير قوي. برضه اللي ساعدنا في حكايه الفراكشنيشن لو التيومر جوه البرين ستيم ميتاسيس، ودي بتبقى قلق لما بندي 1 فراكشن. لكن لو انا عملت فراكشنيشن بيبقى عندي قدره ان انا اقلل برضو الريسك اوف برين ستيم دامج، او حاجه فيري كلوز للاوبتيك تراكت او الاوبتيك كازما مينلي. يعني دي يمكن القصه الرئيسيه، مش عايز ادخل معاكم في تفاصيل، الوقت خلص. بون اس بي ار تي، اي هوب ان يكون في حد هيكمل ورايا. بس برضو من الحاجات اللي احنا بنعملها بقالنا فتره طويله، بس ما نقدرش نقول عليه يمكن the most hopeful way of treating metastasis. البوني سايتس مشكلتها في الاساس الفراكشرز. يعني احنا ممكن نوصل للوكال كنترول رائع جدا، والمريض يجي بعد 4-5 سنين، سواء بقى عملته على الفيمر ولا عالجته على الفرتبري، بيقطموا، والنسبه مش قليله خالص. يعني نتكلم ديفرنت سيريز من 12 يمكن لغايه 30% من الحالات اللي بتاخد هاي دوز اس بي ار تي في البون بيجي لها فراكشرز ليتر اون. وما زال البون اس بي ار تي بالذات من الحاجات اللي يمكن هايلي اكسبيرمنتال لغايه النهارده. الناس احنا كلنا بندور، احنا داخلين لغايه دلوقتي يمكن في 7 ترايلز اوفر ذا ييرز، كل ترايل فيهم يعني كلينيكال ترايل، كل ترايل فيهم مختاره جرعه شكل. مفيش حد عمل جرعه زي اللي قبله، لان كل واحد فيهم شايف كومبليكيشنز مختلفه. فحتى احنا شخصيا ما عندناش ستاندرد قوي، بس بنلعب around 35 grain 5 fractions للبون more or less. take home message ملخص للي قلناه: الاولجو ميتاستاتيك بيشنت عنده potential for cure. الواحد دايما يحاول يلقطه بدري، ما يسيبوش دكاتره الميديكال اونكولوجي لوحدهم يركزوا عليه ويقعدوا يدوا اميون وكيموثيرابي لغايه ما يخلصوا عليه، وبعدين في الاخر ما سوري يا دكتور عماد انا اسف لغايه ما يبقى في الاخر ما فيش فرصه ان احنا يمكن لو لحقنا الاوليجوميتاسيس في الاول فعلا في فرصه ان العيين دولت يا اما لونج تيرم سرفايفل، يا اما نوصل لبعضهم للكيور زي ما شفنا في بعض الداتا عندنا. والاساس هنا selection of dose مع selection of which lesions could be treated to effective doses. وده دورنا احنا كراديشن اونكولوجي. ما اقدرش اقعد هنا وافرض عضلاتي واقول انا اقدر اعالج كله بنفس الافيكاسي. لازم ادي فرصه للديسيبلينز الثانيه برضو انها تعالج المريض بالطريقه الانسب. شكرا جزيلا. اخر سلايد عشان نسيت اشكر الناس اللي معايا في مانهايم اللي ساعدوني في كل الشغل اللي انا عرضته لكم النهارده. عندنا اس بي ار تي تيم طبعا، فراو بودا هيجمان والناس الزملاء اللي معانا. الجاما نايف يمكن الفتره الاخرانيه انا اللي ماسك الجهاز، وبقيه التيم عندنا سواء من الدكاتره او الاستشاريين او النواب اللي ساعدونا في الشغل يعني في خلال السنين اللي فاتت. شكرا جزيلا.
Thank you, Dr. Yasser, for sharing an in-depth experience of SBRT. And as we move forward through the proceedings of our session, I would like to welcome Dr. Ali Hosni, who is an associate professor of radiation oncology at University of Toronto. He is also a physician scientist at Princess Margaret Radiation Medicine Program and a physician scientist at the Ontario Association of Radiation Oncologists. He will be talking to us about the SBRT role in primary and metastatic liver cancers.
Well, thanks very much. And thanks for organizing the committee for this kind of invitation. برضو أنا مصري. I was trained in Mansoura. Dr. Yasser طبعا make it very difficult for me for my presentation because he did a great job. But I will try. So, and I'm going to speak about SPRT for primary and metastatic liver cancer. Here's my disclosure. And I'm going to make it more of a practical pathway through what we are doing, at least at my institution at Princess Margaret in Toronto, with radiation for liver cancer. So I would say it's three steps. The first one is the planning workflow, and the second one is the dose selection for SPRT, and finally the delivery of SPRT. So first we need to select the right patient, and here I'm not going to go more about the indication, but simply for HCC, those who are unresectable or resectable but we need a bridge to transplant, cholangiocarcinoma only for unresectable cancer patient, oligomets if you have 5 or less 5 liver met, and oligoprogression, and we know the difference. Oligoprogression means that you have a lot of lesions elsewhere, but there's probably 1 or 2 spots in the liver that they are growing, not controlled well by chemotherapy, systemic therapy, then we treat with SPRT. And we usually, at least at my institutions, we limit that to 3 lesions, not beyond that. Having said that, sometimes we see trials right now up to 10 patients, up to 10 lesions. So the first step, even before the simulation, is to prepare the patient very well. And for liver cancer, we start with luminal GI preparation, ask the patient for empty stomach, and BO for 2 hours. Then we give the patient lorazepam 60 minutes prior to the simulation and also each time prior to the scan and the treatment. And this is based on our study that we did probably 10 years ago that we included around 60 patients. They give lorazepam and we measure the craniocaudal motion, and we find that this lorazepam with low dose, probably 0.5 or 1 milligram, decreased the mean liver craniocaudal motion by 21%, which is still very reasonable. Then comes with the position of the arm. The standard approach is going arms up. There's other options, including arms down with avoidance of the beam, without avoidance of the beam, or even the right arm up away from the liver. And the group from Netherlands did further and deep investigation for that, and they found no significant difference in the GTV coverage or liver sparing. Having said that, there was some sort of a change in the dose to the spinal cord and the spine itself. Our standard is arms up. We can sometimes use the right arm up if the patient like that. Arms down with beam avoidance, we sometimes do that very rarely, mainly on the MRI machine. And arms down, we don't do it at all. Then you go with the decision of the motion management. As Dr. Yassin mentioned, we make it very easy. Go with ABC, active breath holding, the spirometer. I'm not going to go through that because it's already very well covered. But more than 50% of the patient, unfortunately, will not be able to do the ABC. So the solution we usually use is to do the 4D CT with exhale, inhale, and helical. And the helical will be in the exhale, breathe, hold. And we routinely offer the patient the abdominal compression. Again, this is based on our study that we did probably more than 10 years ago at Princess Margaret with 60 patients treated with liver SPRT. Then we did a sanity 2 and see how the degree of motion with the abdominal compression. And we found more than 90% of the patient will have a change in one of the directions, craniocaudal or anteroposterior. Then that's just the device of the abdominal compression, very simple, and most of the time we do it as soon as we can decrease the residual motion more than 1.5 centimeter. Then you go with the process of the simulation. Like if there's CT SAM, more exciting MR SAM, and even more very exciting MRL. And the idea of having the CT SAM in general is number one, identification and contouring of the target and the organ at risk, and also motion quantification. Simply, if you are speaking about HCC, it's ideally breathe hold arterial and breathe hold delayed. If I speak about cholangio or liver met, most probably we do the standard arterial and venous, and that's it. And if we are not speaking about the ABC, then what we need to do is to just get the exhale and inhale, which is good. You can see the lesion very well, but also if you have the MRSM, they give you more advantage. And once you have more tools to define the tumor and target, you have more chance for success of your management. Very simple, 3T arterial and delayed for HCC, or 3T arterial and venous for other lesions, not HCC. And also we have the CINI, and the CINI can show us the motion quantification. If you have the MRL, then you don't need to go through that. You just go to the MR machine and it will give you T2 and CINI2. And here I'm just gonna get focused more on what you can see in the MR, not the CT, because I know that we see the lesion very well in the CT, but once you go and see it in the MRI and do the contour of the MRI, it's very nice. And you see it easily in sagittal, coronal, you measure 100%, you are seeing the lesion, and it's easy, not difficult at all. And not only the lesion itself, even the demarcation of the organ at risk, the liver. Make sure when you contour the liver that you are not including the gallbladder, not including the IVC when it is totally demarcated, and also make sure that you're contouring the biliary tree. It's very not working very well. Okay, so you can easily see the biliary structures here. And I know that the majority of institutions are contouring the portal vein and giving it a margin, whatever, 2 or 2.5 centimeters to go to the biliary toxicity. But if you are able to see it, why don't you just contour it? Then we can know exactly how much dose we can bring to these structures. And there's always a misconception that you can see the luminal structures and other parts of the abdomen in CT better than the MRI, but unfortunately that's not true with the new MSec sequence. But now we finished the part of the planning, like the simulation. And okay, now, and we say that we did the contours, everyone is happy. Then it comes to the art of the selection of the radiation dose. At least at our institution, this is also in most of institutions elsewhere, we use 5 fractions, and the dose range between 27.5 to 60 gray. This is the standard regimen that we're using for SPRT for the liver. But sometimes we use 3 fractions. Definitely, if you are able to bring the patient to less number of fractions, that's a big bonus for the patient. And the dose range is 24 to 45. Sometimes we go to 60 gray in 3 fractions, and we do that only for lesions which are small, defined by 6 centimeters. And even more attractive, we use the single fraction, even for the liver, like 16, 24, and 30 gray, but they have a very strict eligibility criteria for that. So the GTV should be more than 1 centimeter for luminal or biliary structures. The BTV should not overlap. We allow only single lesion less than 6 centimeter or maximum 3 lesion, each one less than 6 centimeter, and the cumulative diameter less than 10 centimeter. Having said that, if we're treating cholangiocarcinoma, our preferred general approach is to go with a long course, 15 fractions, based on the SWAG protocol, which is available online. And the whole idea is to minimize the toxicity to biliary tree. And now, but again, that's a very large dose range between, let's say in 5 fraction, between 27.5 up to 60. And here is the individualization, personalization is coming from the probability of tumor control and also the normal tissue toxicity. So for HCC, based on a meta-analysis, if you are able to achieve a BED10 of 70, we are relatively okay. And this is equivalent to 40 gray in 5 fractions. For liver met, we prefer to have it more than BED10, more than 100, again, based on meta-analysis that we participated in. And sometimes we target BED 180 because this will give us a more chance for local control. Having said that, again, it's not only the tumor probability, it's also about the normal tissue toxicity, including luminal or non-luminal. Luminal like esophagus, stomach, small bowel, large bowel, duodenum. And here's some summary of multiple institutional data using a range between 25 to 33 gray. And you can see the risk of grade 3 plus toxicity in the duodenum is very low, less than 5%. And those patients, if you go to these papers in details, Those patients who had a duodenal toxicity, either they have a previous peptic ulcer, something like that, or they didn't use the BBI. So for every single patient who with liver SPRT, we recommend using the proton pump inhibitors for 3 months from the day of radiation treatment. This is another meta-analysis which is nice. We can speak about that later on. So the recommendation, if you are planning for SPRT for the liver, the D 0.5 cc to be less than 30 gray, acceptable up to 32 gray, the Dmax point, and we can fight about what's the definition of Dmax point. Does Dmax or 0.035 or 0.01? It's a long process. Make it less than 35 gray, please. Make sure that your patient is using PPI. If there's history of ulcer, more precautious. And if it is in the borderline, let's say that you have a patient, the tumor is very close to the stomach, and the D 0.5 cc is 32 gray, and the Dmax is 35, then I would recommend to go with this treatment each other day. By the way, this data didn't come from the liver, it came from the prostate and pelvic radiation treatment, and they found those patients who had like each other day treatment have a lower risk of GIT or leukemia toxicity. Then the liver, and it's always scary. And we're speaking in 2023 right now that, okay, let's do liver SPRT. It's very easy. But in like in 2000, when you speak with our senior colleagues about it, okay, it was very scary. No one wants to give radiation to the liver because of the risk of radiation-induced liver disease. And if you go back in the literature in 1990s, they quoted a risk of up to 60%. So you give the radiation, patient's gonna die. And there's a long story why they selected these parameters, but at least based on our experience at Princess Margaret, we know that if you have a mean liver dose less than 15 gray, and the dose to 800 cc is less than 15, then the risk of liver toxicity is 0%. Having said that, this is only for child A5. And we can see here, this doesn't work very well, but that's okay. If you see here in the red line, this red line is representing the child A6, minimally change in the liver, baseline liver function. Ends up that with the same dose prescription, 15 gray, then you are going up to more than 40%. You'll be very cautious with these patients. And again, this is the same idea of central hepatobiliary toxicity. This our investment, the biggest investment was from Stanford, and they did a nomogram available online, and they reported for cholangiocarcinoma more than half of the patient will have grade 3 plus hepatobiliary toxicity. So be very cautious. Kidney, there is a lot of data about it. The AAPM 101 report using the critical model volume D200 cc less than 17.5. A lot of clinical trials using mean dose less than 10 gray. But the most exciting part about the kidney, honestly, because it usually doesn't cause a problem for liver SPRT or non-SPRT, unless you have one kidney which is non-functional or removed, and it's always the one away from the liver. It's always the one who is like working is still remaining here. So at that point, we use V1010. So V10 gray is less than 10%. And there's a lot of guidelines everywhere. The one that I really prefer, because it's very simple and easy, straightforward, is the UK consensus. Just search by Hannah and Murray, and you can find it online. Now you go with, you finish with the with the SPRT dose selection, then you go to the process of SPRT delivery itself, and this is the IGRT. So IMRT is one thing, it's great, you do plan whatever you want, but what you're gonna deliver is different. And again, just to make it more exciting, that's the CT SEM here. You see the lesion very well, you are happy. Then come to the cone beam CT, I only see the liver. Then we do the match of the liver. And even we make it more exciting. We did a 4D cone beam CT to minimize the motion artifact. And occasionally, we can see some sort of signal of the lesion, but you can see the lesion itself. But for MRL, you can easily see the lesion just at the time of treatment. And you do the treatment adaptation. Let's say the patient had a rotation a little bit. The liver itself moved, the bowel moved it. It's not only about breathing. So MRL can do that easily. And just this is an example of a patient of mine that we, at the middle of treatment, the patient started to be anxious a little bit, then we hold the treatment and we got an image for at the MRL itself. Oh, wow, the motion is good, we're happy, beam on again. So this is definitely very attractive. So I would like to thank everyone from my original institution in Mansoura and my current institution at Princess Margaret, who always help us develop the GI group at Princess Margaret, and thank you. Any questions? questions.
Thank you, Dr. Ali, for your excellent presentation. And just a comment. Do you think that we can prescribe the same doses in our Egyptian patients?
These doses?
Yes,
So
safely?
yeah, so that's actually a great question. I would say because I'm leading the liver group at the MRL consortium, so I'm exposed more to what's beyond my institution working on. And I would say start with 5 fractions. Start with 30 gray in 5 fractions, very simple. Get an experience for probably 10, 15 case. Once you do it, go to the next step. And if as Dr. Yasser mentioned, you don't need to be high-tech institution to get it. You need to know how to do the process, then get more high-tech. You don't need to get an MRL. You don't need to get even an ABC. You just get the selection of the right patients and go from there. We had an experience with Dr. Khalid when he started, and I was seeing how he's doing, and he did great, definitely. I saw other institutions in Kuwait, Jordan, they are in the same environment here. And they just need to have the protocol start with a very simple, straightforward case. Don't go with 50. For example, I'm doing a clinical trial using 38 gray single fraction to the liver. Don't start with that. Just start with a very simple case. 30 and 5, it's gonna work.
Dr. Amani, just commenting, it's a learning curve. We started like 4 years ago with our first cases of SBRT to the liver, and we started by the cases no one would touch, the cases with portal vein thrombosis or single metastasis or hepatoma just near to the portal vein. And after now we treated like 35 cases on those years, and the learning curve led us to constraints. If you are preserving more than 700 cc's of a good conditioned liver, not a hardly cirrhotic one, and you can go safely with the dose. Most of our cases right now, we are adopting a single protocol to have solid data, 40 in 5. And 40 in 5 actually is safe. And we didn't see a lot of problems after 40 in 5. Maybe if it is very peripheral, near the diaphragm, very close to the intestine, we drop, as Dr. Ali said, to 35 in 5, and it's safe. I'm not pro the 3 doses, but the 35 in 5 or 40 in 5 goes very smooth, and we have patients of HSCC surviving more than 3 years. Alhamdulillah, thank you so much.
I had one patient interesting about the dose for HCC. We know that there is a subgroup of patients in HCC, and I'm focusing more on HCC because we have more patients in Egypt compared to anyone else. And this patient was actually a bridge transplant, very poor performance status. Unfortunately, the wait time for transplant at our institution relatively long compared to their standards, so 9 months, and the lesion is getting bigger. And he was not candidate for TS or RFA. The patient received only 16 gray single fraction, and they went for surgery after pathologic complete response. They didn't find that tumor. So we know from clinical practice and even literature, the data from Toronto, that patient with SPRT, the chance for PCR in general is 20% compared to TACE and RFA is probably around 10%. I'm not against TACE, RFA versus SPRT. We can speak about that later on, but don't put the radiation dose to be your biggest challenge. Biggest challenge is the workflow. Once you get the workflow, start with the usual dose, then go from there. Thanks.
Thank you. Now it's my pleasure to introduce my colleague Ahmed Mustafa, lecturer of clinical oncology in the Minya University and Minya Cancer Center, and he will talk about clinical application of artificial intelligence in radiotherapy. Dr. Ahmed, the floor is yours.
شكرا. مساء الخير وميني ثانكس للاورجنايزنج كوميتي. انا عارف انه اخر اليوم الناس كلها تعبانه، بحاول ان انا اكون فيري كويك. بشكر دكتور علي على المحاضره الجميله بتاع السي بي ار تي في الليفر. وي هاف اكسبيرينس ات ميني انكولوجي سنتر من 2019، بس كنا بنستخدم حاجات مودريتلي هايبوفراكشنيتد 45 جري على 15 فراكشن. وده اللي كان سؤال الدكتوره اماني عليه، انه احنا خايفين دايما من فكره الدوز، خصوصا ان البيشنتس بتوعنا معظمهم سيروتيك وفيرال ايتيولوجي، فالداتا اللي جايه من بره ميبي ان هي تكون ديفرنت عن الداتا اللي موجوده عندنا. ممكن حضرتك شجعتينا ان احنا ممكن نجرب 30 جري ان 5 فراكشن نبدا فيها. My talk today will be about clinical applications of artificial intelligence in radiotherapy. This is my agenda. nearly 20 years ago, our world has been dramatically reshaped by modern computing, and whole industries are now founded on the applications of artificial intelligence. But what we should know first, what is artificial intelligence? Artificial intelligence is a computer science that tries to mimic human-like intelligence in machines that use computer software to perform specific tasks without direct human input. For example, smartphones, search engines, social media channels, speech and facial recognition, self-driving cars, energy-efficient building, and so much more are examples of artificial intelligence. Machine learning is a subunit of artificial intelligence that uses data-driven algorithms that are dynamic and tend to improve or learn as more data are introduced. As you can see here, two sets of images which are similar for a dog and a cupcake. It can do, after training, it can classify images into two sets, A and B. It's called prediction. Deep learning is a subunit of machine learning that uses multi-layered deep neural networks to create a model. An often used artificial neural network is called the convolutional neural network. It just has an input layer like here in the left, and hidden layers which perform processing, and you have an output. To be more simple, you have, if you have an input, feature extraction, classification, you are doing machine learning, and then you have output. For deep learning, it's different. You have input and neural network that gives you an output. And here for medical application, if you have an image through deep learning, you directly get an outcome prediction. If you're using machine learning, you have to do radiomics first, then clustering. Approved clinical applications of artificial intelligence in oncology. Mainly it is applied in the field of radiology. It is more than 5%. We have FDA criteria for approval of machine learning applications. We have clinically approved AI symptoms mini in the radiology, in the pathology, also in the endoscopy. But what about applications in the radiotherapy workflow? We have two main categories: outcome-driven AI, predictive modeling for prognostication, response assessment, and toxicity prediction; process-driven AI for decision support tools, simulation with synthetic CT, automated segmentation, automated radiotherapy planning, quality assurance, and treatment delivery. For prognostication, we have a meta-analysis recently published in the last ASCO. It was showing a multimodal artificial intelligence prognostic biomarker validated across 6 phase 3 randomized trials with long-term follow-up to be independently prognostic factor over standard clinical and pathologic variables for men with high-risk prostate cancer. Also, for GBM, AI algorithms can be used to correlate image-based features with biological observations or clinical outcomes. And with the use of AI techniques for radiomic profiling of GBM, we can predict response and survival in radiotherapy patients with improved performance over established clinical and radiologic risk models. For toxicity prediction, lung toxicity when using SBRT is a great issue, and for patient-specific planning guidance, organs at risk dose prediction using machine learning algorithm can improve organ at risk dose sparing and enhance plan quality. Also, target volume definition is one of the major geometric uncertainties in radiotherapy of locally advanced lung cancer due to delineation variability with tumor normal tissue interface. AI can use local texture to aid the physician in identifying the type of tumor to normal tissue interface like tumor hilum and tumor atelectasis. Also, for response assessment, AI can be used image-based markers for early response of lung tumors to radiotherapy, especially after SBRT, when you have the dilemmas of fibrosis post-radiotherapy. It does this using texture features. Also, for decision support tools, modeling created with the patient and the treatment characteristics can be used for AI-based patient selection for deep inspiration place holding technique in breast radiotherapy. And for simulation, we have what is called synthetic CT. In simulation, CT is still used in many centers, but for brain and the prostate tumors can be seen better with magnetic MRI. And we have many challenges when combining CT and MRI in the workflow. First is accurate image registration, patient scheduling, resource utilization, and reimbursement. As a solution, efforts have been made to develop a CT scan using MR data called synthetic CT scans. It is an AI-based method using convolutional neural networks used to convert MR data to synthetic CT. It can enhance image quality and suppress artifacts and do more accurate image registration. Therefore, in the future, synthetic CT scans with AI-based methods may compensate for the need for CT scanning, as they can be created with electron density data faster and more reliable for plan generation than MR. You can see the images here. Here is to the left the MRI. Next, synthetic CT, bone window and soft tissue window in the brain and the prostate with very clear images. Also, with AI, we can do artifact correction when using 4D CT. You can see images of the 4D CT with correction to the right side using AI-based models. For image registration, AI tools can be trained to determine the sequence of motion actions that result in optimal registration with better accuracy. Manual contouring of target volume and organs at risk makes the process long and has a high degree of inter-observer variability as a result of individual differences. AI can be used to minimize differences between physicians, reduce manual workload, and shorten duration of this step in radiotherapy planning, but still tend to require significant manual editing. You can see this video here utilizing automated segmentation for organs at risk. First case is a head and neck case. It's so easy. You do not need the help from one of the juniors to delineate organs at risk. And yeah, it's like magic. Yeah, all organs delineated in just one click. And another case, lung case. Like a bullet shot, you get all organs at risk delineated. Very clearly and very precisely. For target volume delineation and auto segmentation, we have two ways. The fully automated segmentation, when you do not interfere with delineation of the target and the AI do all the job. They have a good concordance with expert delineation, and the other type is AI assisted contours. On the images to the right, you can see inter observer variability. pointer يعني مش شغال، مش عارف، بس يعني بالتالي واضحه على الناحيه الرايت انه في فرق ما بين الرسم في الصوره، ولما عملنا AI assisted AI خلى الانتر اوبزرفر variability اقل. For clinical validation, we have 5 commercial AI auto segmentation solutions evaluated, and they offer high quality contours and significantly reduce the time compared to manual contouring, and could be used to render the radiotherapy workflow more efficient and standardized. For radiotherapy planning, it is much more complicated, as planning is a very complex process. During planning, humans interact many times with the computer-aided system using their experience and skills to ensure satisfactory quality of each plan. We have many models like automated rule implementation and reasoning, modeling of prior knowledge in clinical practice, multi-criteria optimization. I don't want to go into much details, but you can see in the images above manual clinical plan and below the final machine learning plan. They are يعني very nice job. For quality assurance is a crucial in order to evaluate the radiotherapy plan and detect and report errors. There is many studies addressing application of AI in every step in the quality assurance for the machine. For treatment delivery, we can use target localization, as in this case of prostate cancer to the left side, for pre-treatment setup and real-time tracking using deep learning approach. And at the right side, the synthetic CT can be generated also from cone beam CT with better image quality using deep learning approach. We have challenges limiting implementation of AI. Mainly, we have conceptual challenges as paradigm shifts are challenging. Cultural challenges, AI is often perceived as a toy and unwanted and temporary solution. Technical challenges, high quality imaging, hardware, data sharing infrastructure, and the trained human resources are main obstacles. Financial challenges, as capital investment is required as initial cost is high. But the main issue and the big problem is with data. Machine learning algorithms such as deep neural networks often require large amounts of data. And we have privacy and security issues, lack of data sharing infrastructure, competition between institutions, information used as input for AI system might be not relevant to the task, lack of representative information, lack of good radiotherapy protocols. Also, a big issue is how to evaluate performance of AI systems, as there is no established best practices for evaluating commercially available algorithms and medical AI devices approved by FDA between 2015 and 2021. Most of evaluations performed only on retrospective studies, and we need new guidelines for reporting clinical trial protocols involving an AI component. Humans are great, but have some limitations. They need to eat, they need to sleep, cannot learn everything, cannot do many things at the same time, and have a limited memory. We can make use of AI in radiotherapy to automate tasks that we do often, to create more consistent outcomes in radiotherapy planning, to save time, to employ less people, to increase the number of patients we can treat at our facility. As Einstein said, computers are incredibly fast, accurate, and stupid. Humans are incredibly slow, inaccurate, and brilliant. Together, they are powerful beyond imagination. So we can use what is called hybrid intelligence, where AI systems and humans can collaborate. In conclusion, although AI can take place at every step in radiation oncology, from patient consultation to patient monitoring, and they can contribute to the clinician and the society, there are still many challenges and problems to be solved. Initially, large data sets should be created for AI and then undergo continuing improvement. We do not expect that human knowledge and experience will be totally replaced by AI-based applications that could rather represent an effective supportive tool in diagnosis, treatment planning, and the prediction of side effects and outcomes. The need for big data resources, including detailed data of radiation therapy delivery combined with outcomes, requires collaboration at national and international level to set up large center networks sharing both costs and the benefits of this existing new developments. Surely we belong to Allah, and to Him shall we return. It is with the deepest sadness we share the news of your loss. Know that you are in our thoughts and prayers. May Allah grant you Jannah. Thank you.
Thank you very much, Dr. Ahmed. And now we will call for Dr. Sharif Hassanin. He will present the role of radiotherapy in the management of early breast cancer, updates, controversies, and coordination with surgery.
Thank you and good evening to everyone, and thank to the organizing committee for giving me this chance. This is my frame of the presentation. Regarding axillary management in early breast cancer, this is a gentle reminder of the anatomy of the axillary lymph nodes, which are divided mostly into 3 levels according to the anatomical location relative to the pectoralis minor muscle. We have the level 1 axillary lymph nodes located infralateral to the pectoralis minor muscle, and we have level 2 lymph nodes beneath the pectoralis minor muscle, and level 3 lymph nodes, sometimes called infraclavicular lymph nodes, are superior and medial to the pectoralis minor muscle but below the clavicle. A simple reminder also of the anatomy and radiology, and this is the famous RTOG contouring atlas showing the supraclavicular region, level 3, level 2, and level 1 axillary lymph nodes, and also the internal mammary lymph nodes evident in an axial section and also in the DRR. And this is an example of a radiotherapy post to the internal mammary lymph nodes. A very important and basic information during giving whole breast radiotherapy by opposing tangens, that level 1 and 2 are mostly included in the breast tangens, and that there is a significant incidental dose of radiotherapy delivered to the axilla, level 1 and 2 axilla, I mean, with the use of the standard tangens, and even the use of high tangens may deliver a higher dose of radiotherapy to the level 1 and 2 of the axilla, and better coverage of level 1 and 2 of the axilla can be achieved with high tangens and modern techniques without increasing morbidities. Remember that level 1 and 2 of the axillary nodes receive significant dose radiotherapy from the whole breast irradiation, but it may not be enough dose if you are targeting level 1 and 2 axillary lymph nodes as a target volume in your plan. A very basic question and famous one: radiotherapy or surgery in clinically node negative patients, and can radiotherapy replace surgery regarding the axillary lymph nodes? We have an old and important trial, the NSABB-B04 trial, which compared mastectomy with axillary lymph node dissection and mastectomy with regional radiotherapy and mastectomy alone in patients with clinically node negative disease. The 10-year survival rate was similar in the three groups. Axillary failure rate was significantly higher with mastectomy compared with those who underwent radiation or axillary lymph node dissection. So we can conclude that post-surgery and radiotherapy can give similar results, but at the end of the day, we need to treat the axilla either by radiation or surgery. In practice, right treatment for the right patient, surgery and radiation are complementary. We do them together to reach a right treatment plan for the patient. Let's start by the patients who underwent upfront surgery, and we have two main scenarios: patients who underwent axillary lymph node dissection and those who underwent sentinel lymph node biopsy. In pathologically negative patients who have no pathological metastasis in the axilla, mostly no regional nodal irradiation will be given. You may consider to give RNI in some scenarios such as T3 tumors or T2 tumors with some high-risk features, grade 3, ER negative, and so on, but mostly you will not need to give regional nodal irradiation in patients with pathologically negative axillary lymph nodes. Regarding patient with pathologically N1 lymph nodes, and this is a very important category of patient nowadays because there was a major change in our practice in the recent years due to the development of the concept of sentinel lymph node biopsy instead of axillary lymph node dissection in patients who had low axillary disease burden after the publication of the AMAROS and the Z11 trial. We all know these two famous trials, the Z11 and the AMAROS trial, which tried to replace axillary radiotherapy to completion of axillary lymph node dissection in patients with one or two sentinel lymph nodes. But regarding the radiotherapy target in these two trials, we should mention and we should remember that there was a significant difference in the target volumes regarding radiotherapy in both trials. In the Z11 trial, all of the patients underwent breast conserving surgery and they only received whole breast irradiation after the operation with no specific or dedicated axillary field. The Z11 investigators adopted the concept of low disease burden and they thought that only the whole breast irradiation by opposing tangens is enough to cover the axilla, and so omission of axillary lymph node dissection can be done, and the rates of the outcomes were excellent. But at the same time, the AMAROS trial, although with a very similar inclusion criteria and a very similar design, but comprehensive regional nodal irradiation was done in the trial, and they irradiated level 1, 2, 3, and even medial supraclav after the operation, and also they allowed for mastectomy patients. So now we have a very common scenario nowadays: patient coming with N1 disease after sentinel lymph node biopsy, one or two lymph nodes only are affected. What we will do after the operation, we will give radiotherapy to the axilla. I think whole breast irradiation is not enough. We should give dedicated treatment and coverage to level 1 and 2 axillary lymph nodes. If you feel that your patient is a high risk one, she has ER negative tumor, for example, high grade, something like this, you may irradiate all axillary levels from 1 to 4 according to what is done in the AMAROS trial. So each case is individualized in this scenario. Regarding the cooperation between the oncologist and the surgeon before the surgery, we all know that the Z11 trial included only patients who underwent breast conserving surgery, and Amaros trial only 17% of patients had mastectomy. So with the publication of the two trials, there was a concept, or there was an idea that only patient with breast conserving surgery can apply the protocol and can omit axillary lymph node dissection, and that mastectomy is not allowed. But there is no reason to believe that the efficacy of nodal radiotherapy varies based upon the type of breast surgery. So in patients with mastectomy who have an indication for post-mastectomy radiotherapy based on the presence of one or two sentinel lymph nodes, axillary lymph node dissection can be avoided. If the local guidelines give your patient post-mastectomy radiotherapy, if she had only one or two sentinel lymph nodes, the surgeon can avoid axillary lymph node dissection and do instead sentinel lymph node biopsy, given that the patient will receive post-mastectomy radiotherapy and regional nodal irradiation to the undissected axilla. Back to the NCN guidelines. Patient with N0, as we said before, mostly they will not receive regional nodal irradiation after the surgery, except in some special scenarios. On the other hand, on the other extreme, patient with N2 disease will mostly go for axillary lymph node dissection and regional nodal irradiation to levels 3 and 4, and maybe internal mammary lymph nodes. Patient with the medium or between the two extremes, one or two or three positive axillary lymph nodes, you should individualize the case. You should apply the criteria of Z11 and Amaros trial, and you can give only level 1 and 2 axillary lymph nodes, or you can extend your target to include all the levels of the axillary lymph nodes. The same applies to mastectomy, as we said before. What about the more complicated scenario nowadays, patient coming from neoadjuvant therapy or primary systemic therapy? We should all know that prospective data in these contexts are very scarce, and that guidelines and indications concerning post-operative local regional radiotherapy are mainly based on trials evaluating a patient treated with upfront surgery. Therefore, clinical evidence about local regional treatments after neoadjuvant treatments are less robust and less clear, and the indications for radiation in this patient population after the use of neoadjuvant treatments are mostly based on retrospective and pooled analysis studies. To cut it short, to try to summarize, patient with N2 at presentation will receive combined modality, axillary lymph node dissection and nodal irradiation, because any high axillary disease burden necessitates combined modality. For patient with N2 or N3 after dissection, regardless of the response, radiation target volume should include the undissected axilla. In patient with high nodal disease burden, either before or after the neoadjuvant treatment, axillary dissection is recommended, and as we said, the volume should include only the undissected breast lymphatics based on the EORTC 22922 trial. Try not to irradiate the axilla or the part of the axilla which was dissected, in order to not increase the morbidity and lymphedema. Up till now, patients with clinically positive lymph nodes at presentation will receive regional nodal irradiation. The current major guidelines in most cases strongly recommend RNI with avoidance of the operated axilla for both clinical and pathological nodal involvement. Up till now, guidelines, patients with N1 at presentation, if she received neoadjuvant treatment, she will also receive RNI after the operation. A St. consensus in 2021 made a strong recommendation against omission of RNI for patient who was presented with clinically positive axillary lymph nodes, and as we mentioned before, radiotherapy is given to the part of the axilla that was not operated. What about if we have a patient with sentinel lymph node biopsy after the neoadjuvant treatment with any malignant residual disease? Can we apply the same concepts of Z11? Can we apply the concept of low axillary disease burden and omit axillary dissection? The answer up till now is mostly no, because data coming from different studies pointed that the possibility of presence of metastasis in non-sentinel lymph nodes, if the patient has any residual malignant cells after neoadjuvant treatment, is high. And real-world data coming from the National Cancer Database suggested lower survival when substituting sentinel lymph node biopsy and RNI for axillary resection when any type of residual nodal disease is present. And so the panelists of St. Gallen in 2021 also recommended against omission of dissection and replacement by radiotherapy in any patient with any type of residual metastasis in the axilla after the use of primary systemic therapy. What about target volume? If the patient has still pathological lymph node after the neoadjuvant treatment, the standard of care, the patient will go for axillary dissection and you will irradiate the undissected part of the axilla, and you may also consider internal mammary nodes. If the patient does sentinel lymph node biopsy, which is up till now not standard, but if it was done, so the patient will receive radiation to all axillary levels, 1, 2, 3, and internal mammary lymph nodes should be also irradiated. What about patients who achieved pathological complete response in the axilla, and mostly they are coming from sentinel lymph node biopsy? We will do some radiotherapy similar to what was done in the Z11 and the AMAROS trial. We can irradiate level 1 and 2 and interpectoral lymph nodes, and this comes from a recommendation of a multidisciplinary expert consensus called the Lochrine Toolbox 2. So if your patient achieved the BCR and she underwent sentinel lymph node biopsy, you can irradiate level 1, 2, and interpectoral lymph nodes after the operation. And this is a very important scenario in cases where the lymph nodes converted from N1 to YPN0. The oncologist should review the pre-treatment images and the surgical pathology reports to understand the initial and post-primary systemic therapy extent of nodal disease, including the levels involved, and fusion of both images before and after treatment should be done if possible. What about de-escalation? Do we have any room to omit or don't use RNI in patients who achieve the BCR? As we mentioned before, the guidelines still up till now recommending against this, but many data in the recent years, in the 2 or 3 past years, said that we may consider de-escalation for radiotherapy and that it can be omitted, may be omitted in patients who achieve BCR and were initially N1, either they underwent dissection or sentinel lymph node biopsy. More factors may motivate the oncologist to omit RNI, especially if the breast also has BCR and the patient is older age. So maybe some data reveal that we may de-escalate the radiotherapy and we can omit RNI in patient achieving BCR after the primary systemic therapy. Here is a prospective randomized trial called the RAPChem trial. It's an ongoing trial, but we have preliminary data after 5 years of follow-up. The protocol of this trial depended on categorization of patients into 3 categories: low risk, intermediate, and high risk, according to the pathological response of the axilla. They considered patients with PCR to be low risk, those with N1 after treatment to be intermediate, and those with N2 after neoadjuvant treatment to be high risk, and they give the radiotherapy according to each risk criteria. In the low risk patients, only whole breast irradiation. In those with intermediate risk, they give them chest wall or breast irradiation with radiotherapy to the level 1 and 2 in case of sentinel lymph node biopsy, and in high risk patients, all axillary levels were mostly included. The 5-year results are published recently, and the study was positive regarding this scenario or this categorization, and the radiotherapy was given in a hypofractionated schedule. After median follow-up of 5.8 years, the primary endpoint was met, and the local regional recurrence rate was almost identical in the whole group with no differences. Even in the post-hoc analysis conducted to this trial, because they found that many of the centers which entered in the trial did not strictly follow the guidelines, especially in the patient with intermediate risk disease, and they may escalated radiotherapy. So they did a post-hoc analysis only for patients who were followed by the strict study protocol, and also the primary endpoint was met. And at the multivariate analysis, triple negative disease and grade 3 tumors negatively correlated with relapse-free survival, and very important that complete response to neoadjuvant treatment showed an independent favorable correlation many ongoing trials are now open to evaluate the concept of omission of surgery, I mean dissection, and replace it by radiotherapy in patients to achieve BCR. One of the most important trials maybe is the Texas trial, what's called tailored axillary surgery, and the design of the trial is somewhat complicated, but the main objective of the trial is to test the hypothesis that treatment with tailored axillary surgery and radiotherapy is non-inferior to dissection in terms of disease-free survival of breast cancer patients, and the results of the trial are still awaited. Also, we have another trial called the Adarnet trial in the same context. Regarding the internal memory nodal irradiation, all of us know that we have no solid answer for this irradiation of the internal lymph nodes, but we have a famous trial reporting 15-year results of the radiation to mammary lymph nodes, and they concluded that mammary lymph node irradiation is beneficial in right-sided breast cancer patients in order to avoid the cardiac toxicity which may happen in left-sided cancer patients. No consensus about the internal lymph node irradiation, but it is strongly considered in N2 and N3 medial and central tumors can be omitted in left-sided breast cancer patients. Regarding the fractionation, we all know that the START A and START B, the very famous trials evaluating the use of hypofractionation in breast, include only patients with early breast cancer cases, and mostly they have done breast conserving surgery. And so at the beginning of publication of these trials, many physicians and many oncologists may be reluctant to use the same hypofractionation in patients with N positive, but in real world data and the long term follow-up of these START A and START B revealed that there was no added toxicity and that regional nodal irradiation can be given in hypofractionation.
Dr. Sharif, معلش لو we are restricting to the time, please. If you can summarize it.
So our take-home message, axillary management by surgery and radiation are complementary. Patients who have heavy axillary burden need combined treatment with both surgery and radiation. Radiotherapy is always given to the undissected parts of the axilla. The use of axillary radiotherapy to de-escalate the axillary surgery from resection to sentinel lymph node biopsy is evolving every day. The optimal use and targets of RNI in patients receiving neoadjuvant treatment is a matter of great debate, but most current guidelines still advise for RNI after surgery in patients presenting with nodal positive disease. Many ongoing trials are assessing the feasibility of de-escalation of axillary surgery and the optimal use of nodal irradiation. Hypofractionation is safe. Internal mammary irradiation is mostly used in right-sided cancers presenting with AV nodal disease. And thank you.
Thank you very much, Dr. Sharif Hassanein, for your interesting topic. And we'll let the question for the end of the session. And now I present my dear friend, Dr. Radwa Hamdi, lecturer of clinical oncology, Qasr Aini University. And the topic will be about 1,000 cases of cancer cervix, Qasr Aini brachytherapy experience.
Thanks for the kind invitation for the committee. Thanks, Dr. Reem Ahmed. First of all, we have started high dose rate brachytherapy unit Qasr Al Aini from 5 years ago. Dr. Ahmed, the leader of the brachytherapy unit, got for us plenty of applicators, and we have to use it. And we have to start to put the protocols. And we have the main problem for us is the contouring, as we get all the experience from the Indian experience or the Indian training experience. So we have started our unit 2019, and after having our training in Bangalore Ramaya Center, and we follow their all protocols without modifying anything. And we all of us know that the contouring in brachytherapy is through MRI based. So we have plenty of applicators, all the types, Fletcher, ovoid, ring, interstitial gynae template, and tulip or Vienna ring. But we didn't have MRI based contouring. We only have CT, so we have to start the era to change from the 2D to 3D, as we have already low dose brachytherapy and 2D techniques before, depending on calculation on X-ray. So we based our protocol using CT. We settled the simulation based on CT simulation after putting the protocol, and we first of all try to do some sort of MRI fusion on the planning system to modify our contouring, or to have just blending the contouring for the system, as no published yet data was still established for the CT contouring by the history or the JAG history. And then the crucial year was the 2021. Here the JAG history ABS recommendation for CT-based contouring guided adaptive brachytherapy was published by the leader Dr. Amish, and he put a very important point that clinical the minimal requirements is to have a good clinical assessment and documentation, which still will be the most important, and to have either CT or MRI based at the time of the diagnosis, and a CT using applicator in place to do the contouring on. From that point, we have changed our practice, or the point to change our practice using CT on the contouring on just settled or published data. Here, all we know that this famous diagram or schematic diagram, when you have your patient, you have to do a very important mapping, clinical and radiological mapping. It's very important session by session. So you have to know the height of and the width, and a new term have arisen in this publication is the near maximum distance for the tumor for both sides of the parametrium. Also the vaginal disease extension, and which depending on clinical and radiological. So we have a new term, which is the CTV high risk volume dimensions, based on this diagram and based on a lot of tables which settled by the JAG Istro, or the new JAG Istro CT contouring base. So we stick to this table, and we started to do our contouring on this table, high risk volume CTV, depending on MRI at diagnosis and pre-brachytherapy MRI. At that time, pre-brachytherapy MRI is mandatory for us. We have to do for all patients coming asking, as we are referring center, and not most of our patients, about 95% of our patients is referred from other centers or referred from all over the regions. So we ask for brachytherapy MRI, and we do CT at the time of a brachytherapy. At that time, we didn't still yet started doing any sort of modification by doing just like transabdominal ultrasound, or transrectal or transvaginal. So this is a very important and crucial table for who are going to start brachytherapy contouring on CT based. As new staging or adaptive staging on stage 1, which confines the lateral boundaries of the cervix. Stage 2, which in my own opinion is the most different from MRI-based contouring, as stage 2 is always our main problem is the parametrium extension or the parametrium disease, which is a gray zone. Maybe we can't comment on it on the CT based delineation. So we have to stick to this one. Stage 2 brachytherapy, proximal parametrial divided by clinical and also by maybe by transvaginal ultrasound guide. MRI pre-brachytherapy is very important to comment on the pre-brachytherapy MRI. Also, stage 3 or stage 4, almost the disease is still advanced, and we are going to delineate on CT. In my own opinion, it doesn't difference a lot from the CT from MRI, but still the adaptive and the field of radiation and adaptive every session is a very important point of view for the brachytherapy. Here's a diagram by the Jack Istro published. MRI diagnosed at the time of the diagnosis, disease mapping at diagnosis, the blue one, and the shaded blue is the disease mapping and the brachytherapy, and the vaginal extension at what the CTV volume high risk, which wasn't settled in our center for the first 2 years. حقيقة احنا كنا بنرسم كل ما هو الجروس فقط لا غير. طبعا depending on ال MRI ال pre-diagnosis. طيب في important يعني important definitions ظهرت في الحقيقه في الجاك استرو اللي هو السي تي بيز، اللي هو الهاي ريسك سي تي في فوليوم اللي احنا بنرسمه الانتاي سيرفكس واي سيرفايكال اكستنشن. الديفينيشن بتاع النير ماكسيمم ديستانس او الاكستنشن بتاع ديزيز من السيرفايكال اوس للباراميتيوم سواء الليفت اور رايت. وفي important very important اللي هي ترانس ابدومينال الترا ساوند، اللي هو ده بصراحه كنا نفسنا جدا ندخله in our own center عشان لو كوست. واحنا طبعا كلنا عارفين اللوجيستكس بتاعت اي developing countries واي مشاكل بتقابلنا، كان طبعا من ضمنها التخدير والعدد السيشنز والبروتوكولز وطبعا الام ار اي which يعني حاجه من قبيل المستحيل اللي احنا نعمله في القصر العيني، اللي انت بتطلب ام ار اي للبيشنت ده يعني حاجه صعبه جدا. فكنا عايزين نموديفاي الرسم بتاعنا او الكونتورنج بشيب ميثود او بميثود نقدر نحدد فيه او نقدر الانسرشن يبقى افضل طبعا، لان احنا طبعا كنا برضو بندبند على بلايند ميثود اند كلينيكال ميثود اسسمنت اي يو اي، وحتى ان ذا سيم سيتنج في التركيب، لان ما كانش عندنا رفاهيه التخدير اللي احنا نخدر البيشنت فور اي يو اي مره ونخدر للتركيب مره. فكنا بنأسس فور اي يو اي blind method for insertion of the tandem or interstitial needles even, and do the CT simulation and modify after the CT simulation after insertion of the applicator or the needles, which is very difficult. So we decided اللي احنا بصراحه نبدا ندور شويه في موضوع الالترا ساوند او الالترا ساوند جايدد انسرشن، والالترا ساوند كان نفسنا بصراحه جايدنج كونتورنج. ففي several studies الروتين يوز اوف الالترا ساوند تندم، طبعا معظمها من الانديان لان الانديان زينا شويه developing countries، فكان البروبر بليسمنت بتاع التندم والتشوز اوف البروبر تشوز اوف الابليكيتور، لان كل في كيسز يعني هوريها لحضراتكم كل كيس السيشن عن سيشن بتفرق الحقيقه، وبيتغير يمكن شكل الانجل وشكل اليوترس من سيشن فيرست سيشن للثيرد سيشن. طيب احنا كان بصراحه نفسنا جدا دي ستادي استخدموا الكونتورنج بيزد اون التراس او الترانس ريكتال الترا ساوند، وده يحتاج حاجه بسيطه، وان اللي هيأسس او اللي هيشتري سنتر او اللي هيشتري يعني سونار في السنتر بتاعه ان هو يكون داي كونفرجن او يقدر ينقل الصور دي. الحقيقه ما كانش برضو عندنا الرفاهيه دي، احنا كان سونار عندنا واخدنا يعني كان سونار اوريدي موجود، يا دوبك اشترينا كذا بروب او قدرنا نشتري فاجينال بروب ونيو ابدومينال بروب ونبدا نشغل الجهاز او نشغل او نعمل الترا ساوند جايدنس انسرشن. طيب كان طبعا this is our eminent assistant professor thesis دكتور مارين from المانيا center trainee at our center. هتنقل لكم التجربه كامله يا دكتوره اماني. احنا الاول جبنا طبعا حد راديو دايجنوزس، يعني انا بنشكر طبعا دكتوره ياسمين عصام، هي كانت اللي علمتنا او جت معانا في الاول طبعا during الانسيرشن، علمتنا احنا we are not good sonarists، بس just اللي احنا طبعا في المعلومات دي اللي تهمنا او اللي احنا طلعناها ان دي اللي تهمنا اثناء التركيب. اول حاجه الانتيرو بوستيرو فيرتيكال، بنشوف الجروس ليجن ستيل ان ذا سيرفكس، الشيب بتاع السيرفكس، الانجل بين ذا سيرفكس اند يوترس، والسيرفايكال كانال فيجواليزيشن، والريليشن ما بين السيرفكس والبوستيرو بلادر وول، لان دي يعني في لاين اوف كليفج او سسبكتد انفلتريشن، لان دي الحقيقه دايما الايشو بتاعت الكونتورنج او الاكسبتنس بتاعت البلان بتاعتنا. طب الاكزيال فيو اسسمنت اللاترال، طبعا قدرنا برضو ناسس شويه، يبقى عندنا شويه معلومات عن البارامتريوم، وكلمه دايما كنا بنشوفها سمادج بارامتريوم او يعني جراي زون اوف بارامتريوم، دي برضو قدرنا نطلع ان الاسسمنت من المعلومات البسيطه من السونار. طبعا هو شيب اند يعني افيلبل ميثود وموجوده ونقدر بسهوله جدا. طيب ده بيفرق معانا في التشوز بتاع الابليكيتور، هو ذا سيم سيتنج، القصه كلها او ان احنا نقدر نعمل في ذا سيم سيتنج اي يو اي، نخدر العينه، نعمل اي يو اي، نعمل ايميجينج مابينج، نعمل كلينيكال مابينج، وده الهدف كله، اللي انا اختار الابليكيتور المناسب واقدر اوصل انا مش شرط يبقى عندي ام ار اي بيز ديلينيشن او عندي احسن حاجه طبعا مع الهاي فلو سنترز بالذات، بس اقدر اوصل اللي انا اختار الابليكيتور المناسب، لان ده برضو بيختلف اختلاف كبير قوي الحقيقه. يعني اللي انا اختار رينج زاويه 40 من زاويه 60 من زاويه 30 من اختيار فليتشر من ريتروفيرتد يوترس، يعني قابلنا حالات كتير قوي ريتروفيرتد يوترس او اليوترس مقلوب اون ذا سيكرم which has different techniques او عملنا different techniques في الحالات الادفانسد and the insertion of needles and to avoid اليوتراين artery طبعا which is the main يعني consensus عندنا. الانجوليشن الفيجواليزيشن بتاع الكانال نفسها، في كلينيكال برضو ايشوز كتيره جدا، لان كل مريض وكل اناتومي مختلفه عن الاخر، يعني في بنلاقي عيانين very narrow vagina and very high os and the os is in the pelvis and you can't reach clinically. راديولوجيكالي يبقى باين الام ار اي اليوترس از فيري ويل كونفايند اند انت الانجل ايه، وبنبقى مش عارفين الحقيقه نوصل للاكسترنال اوس كلينيكالي، ده نتيجه للفيري نارو او الفيري تايت فاجينا. السونار ساعد برضو في الحقيقه في الحالات دي جدا، اللي احنا ما ندخلش في البوستير فاجينال فورنيسز، واللي احنا نقدر ندخل في التراك مظبوط، لان بتبقى كل حاجه فيجواليزد اون ذا سبوت اور اون ذا تيبل يعني. طيب في بعض الكيسز احنا عالجناها، احنا استخدمنا السونار الحقيقه في اخر سنه ونص لسنتين، طبعا قعدنا 6 شهور السيستم ال 2 دي ولا 3 دي، ما قدرناش الحقيقه نجيب 3 دي، كنا نفسنا نجيب 3 دي ما قدرناش نجيب 3 دي، جبنا سونار عادي خالص بفاجينال بروب وترانس ابدومينال بروب، والفاجينال يعني ترانس ريكتال وترانس فاجين. طب دي بيشنت عندنا ستيج 1 بي، كان الام ار اي ابدومين بلفس الماس 6 باي 5 and 5، external obliterating the external os, no uterine extension and no vaginal extension and no lymph node, received the concurrent chemo radio at the NCI and referred to our department. New pre-brachytherapy MRI كان regressive mass 2.7 by 2.9 centimeter and there is a stranding of parameter. هنا الحقيقه التو سونار او الصورتين الاولانيين السونار ادتنا داتا عن حاجتين، اولا وضع اليوترس او الانجل اللي انا ممكن استخدمها لليوترس، هي صوره الام ار اي بتاعت ذا سيم بيشنت اللي هي البري براكي اللي هي تحت هنا clear visualization of the cervical canal. الماس is very limited to the cervix. اليوترس is high in the pelvis and tight or narrow vagina with no tumor extensions or no tumor extensions to the uterus. هنا الحقيقة الأطوال بقى مهم جدا في تعليق السونار، لأن احنا عندنا 3 أطوال ثابتين أو الأطوال الثابتين في الرينج سيستم عامة بتبقى 6 و4 و2 سنتي. فاللي احنا ما نستخدمش مثلا طول نعمل بيرفوريشن لليوترس او نعدي الفندس بتاع اليوترس، ده بيبقى الكومنت من خلال طبعا السونار بيبقى كويس جدا. هنا بيفور، هنا الاول صوره ده قبل ما الرينج تبقى لوك، وهنا افتر الرينج لوك، لان ساعات اما بنلوك الرينج بيبقى التندم نقدر ننزل بيه شويه في جزء الفاجينا، فما بيبقاش ذات هاي، فبنقدر نحدد احنا عايزين ندخل مش قد ايه، او الطول اللي احنا عايزين نغطي بيه السيرفايكال كانال قد ايه. طبعا في سيستمز تانية بنقدر نحط فيه ستوبرز زي الفليتشر او الاوفويد سيستم. طيب برضو اي تيوبال ليجن فيرسس السي تي ليجنز بتبقى باينه وظاهره. هنا في تيوبال ليجن هنا فباينه جدا. نقدر بالترانس فاجينال الترا ساوند نعلق على البارامتريوم او الستراندنج، كلمه ستراندنج بارامتريوم. السيرفايكال كانال نقدر ناخد طوله كويس قوي. وضع اليوترس، وضع اليوترس. طيب هنا الكيس دي بسرعه، ان العينه دي كانت تبان في البري في الدايجنوزز MRI انه انتي فيرتد يوترس، وده بعد الكونكرنت كيمو راديو دخلت في CR، فاليوترس رجع لوضعه او الريتروفيرتد يوترس. هنا طبعا اهميه السونار في الجاينس او الجاينس بتاع الانسرشن، ان لو ركبنا على الوضع القديم او البري MRI ما كانش طبعا هيحصل بيرفوريشن او هندخل في البلادر. هنا الريتروفيرتد يوترس ليه a lot of techniques، يا اما نقلب الابليكيتور، يا اما جريبنج او ابدومينال جريبنج ونعدل اليوترس والسيرفكس، ودي بتبقى صعبه جدا في حالات الفايبروزز افتر كونكرنت كيمو راديو. ففي الاغلب بنختار اللي احنا نقلب الابليكيتور او نختار زيرو انجل اللي هو الفليتشر انجل. هنا دور السونار مهم جدا، اللي احنا طبعا وضع والانسرشن واللي احنا ما ندخلش في البلادر. ودي يعني انا هجري بسرعه. اخر حاله دي advanced case with upper uterine extension. ركبنا فليتشر او what is called the tulip insertion. tulip او فيينا tulip ده as the Vienna type with ring and interstitial needles around the parametrium disease. So انا هجري طبعا عشان taking home messages that if you are going to establish brachytherapy unit, you have to do the first and the most important, a map for each session for the patient, map clinical, which is very important, map radiological, depending on either MRI once at the diagnosis and CT, ultrasound, using the transvaginal ultrasound and transabdominal, and the best is transrectal. Guided insertion is an easy and acceptable, cheap way, high rate centers and in developing countries, and very accurate. And you have the possibility to do contouring if you have DICOM version sonar or DICOM vision. The best to have pre-diagnosis and pre-brachytherapy MRI, but if you don't have that, the timing for the insertion is very important. You have to stick to the time, as this will improve the local control and the survival for the patient. So don't wait for the MRI. You can do either ultrasound and or do CT contouring.
Thank you very much, Dr. Radwa, for this beautiful talk. I wish we had more time, but unfortunately we're very running out of time. Thank you very much. And now I have the utmost pleasure and honor to present my dear professor, Dr. Medhat Sidai, former head of Radiation Oncology Department at National Cancer Institute, and his talk today will be about the recent trends in breast cancer radiation.
Thank you very much, Dr. Reem. I really appreciate your effort having this event on the floor, reality on the floor. Yes, please. تاني لو سمحت. I would like to thank all the audience for being there for maybe 8 hours. It's 8 p.m. right now. I know you are tired, but I can promise you, you will not regret it, especially the coming presentation by my dear friend Ramon Ramses. You will enjoy it much better. So I'll go What is it? This is forward. Okay. I don't have any disclosure. It's not one-man show. And I will take this opportunity to thank all my team members, either at NCI, here on the right-hand side, or at Nassau City Cancer Center on the left side. It has to be mentioned that working at Nassau City actually was a pleasure. The machine started working by 11th of November 2019. And the image on the left, or actually on the right, it's the new machine installed at the breast cancer hospital at first in a settlement, and it started working by the 12th of December last year. It's amazing how ancient Egyptian recognized very well and in details the anatomical composition of the mammary gland more than 7,000 years back. When it is indicated, radiation therapy have served breast cancer nicely and significantly improved local control, reduced the disease-specific mortality after mastectomy, and not only after mastectomy, but as well after conservative approach of breast cancer for either negative node patients or positive node patients. Bilateral breast cancer actually is a clinical, challenging and psychological problem for the patient. What we used to do is to perform a 3D plan, simple 3D plan, and usually we do respect the dose constraints. It used to work nicely. Some difficult cases we may refer to VMAT or IMRT, but surprisingly that the dose spillage with the VMAT up there is much wider than using the 3D. The pink color wash represents the 50% of the dose. As you see, 50% of the dose is covering more volume of the lung with high-tech VMAT. So we start with 3D. If it works, it's nicely to go and start. If it doesn't work, we have to refer to VMAT. In 2012, actually, we have our Ramon here. We started accelerated partial breast irradiation. Initially, we started with twice a day, 38.5 grams in 10 fraction. Then when we got busy at the department, we changed the protocol to 38 and 10 fractions once daily, and we reported the treatment results. There was no significant difference, and both served well with nice cosmetic results. In 2015, we started to develop deep inspiratory, voluntarily deep inspiratory breast hold for patients with breast cancer on the left side, and our aim was to reduce the dose, reduce the dose to the heart, and it worked nicely as well. It needs some simple coaching, and patients usually follow the instructions, and it has significantly reduced the heart dose for such kind of patients without compromising the coverage of the PTV of the breast. In 2015, because we are getting busy at the department, we started to develop a simultaneous integrated boost for patients with breast cancer following conservative approach. When boost is indicated, we delivered 40 grays to the whole breast and 48 to the tumor bed, all in 15 fractions. And again, it worked nicely without any cosmetic disfigurements. In 2015, we got the applicator for the prone position, and we used it to treat patients with huge-sized breast. On this side, this is an ideal setup. This is not the ideal setup. This patient has been referred for surgery to get mastectomy done and save her the radiation therapy. It's a very simple technique. Actually, it reduces the thickness of the breast. So you use lower energy, it protects, or it reduces the dose to the heart, especially on the left-sided patients. and of course reduces the dose to the ipsilateral lung. It's indicated only when patients have negative nodes. In 2017, we started to use ultra-hypofractionation in breast cancer management, either fast or fast-forward protocol. It worked very nicely, especially during the COVID-19 era. And of course, the ultra-hypofractionation has different dose constraints that it has to be respected as usual. And we reported our results. There was no much difference regarding cosmesis or local control. We experienced a bit higher incidence of acute side effects, but it was comparable outcome by the end of the day. These are some few examples at 2 years follow-up. In 2021, actually, we started the protocol of using radiation therapy in the neoadjuvant setting, side to taxanes in patients booked for neoadjuvant chemotherapy, those who have got T3, T4 disease, and we later on added triple negative and HER2 positive patients to such protocol. To summarize it, with the patients who have been booked for neoadjuvant chemotherapy, according to the multidisciplinary team, patient starts with 4 cycles of EC. Then with the beginning of taxanes, weekly taxanes, we start our radiation therapy course. It worked nicely, and down here is the maximum skin reaction we got, stage 2 at the inframammary area. Last year, we detected a complete pathological response rate of 53. This year, it went down to 42. And when we say complete pathological response, when the patient finished with the radiation therapy and the 12 weeks taxane, she goes for surgery as planned, and there is no evidence of active tumors either at the primary site or at the lymph node. Last year, the initial results were 53, mainly triple negative and HER2 positive, and this year it went down to 42. Last ESMO this year, they reported phase 2 trial, about 50 patients who went through the same protocol, and they followed them up without any surgery for more than 3 years. So it sounds like a good option. In 2022, we got our ABC system. It's not functioning yet. We're still waiting for the training. This year, we started stereotactic body radiation therapy for oligometastatic breast cancer patients, where, like we heard earlier, from 1 to 5 lesions. This is an example of one of these patients who had a solitary lesion at the neck of the left femur. We adapted the protocol to deliver one single dose of 18 to 24 gray in one fraction according to the anatomical site, and it works nicely. We start this stereotactic single dose on day 0 before the patient started chemotherapy, aiming at to improve the quality of life, reduce pain, and minimize the risk of fracture. This year as well, we started another protocol of neoadjuvant SBRT boost to the tumor bed. It's one single fraction of 12 grays delivered in the prone position to the tumor bed before the patient goes for chemotherapy. The advantage is you can see the tumor very well. You don't need to insert clips, and you have the CT simulation on day 0 before she starts chemotherapy, so there is no much changes in the volume. In prone position to reduce to or to minimize the dose to the lung, ipsilateral lung and the heart, in case the patient comes again for adjuvant dose of radiation therapy. Of course, we follow the dose constraints in such setup. This is a bigger or another patient on the left side. We used VMAT, and you can see the dose is very well conformed around the lesion. We have some issues with the radiotherapy implants. In this patient, this is a premenopausal lady who got mastectomy, skin-sparing mastectomy, and the surgeon adapted immediate silicone implant. And then this is day 0. On day 0, we did the CT simulation. Midway, during seeing her at the floor clinic, there was some changes in the shape of the diseased breast. When we repeated the CT simulations, there was some shrinkage of the silicone implant, which is reported. Another complicated case who got a silicone implant plus latissimus dorsi flap, complicating our life much more, because these patients usually develop fat necrosis, and it lives for years, looking suspicious on radiology, and sometimes we resort to biopsy it, and usually it comes negative. So the message here is we do prefer to have whatever breast reconstruction done after the radiation therapy. We're still, unfortunately, receiving such kind of patients with advanced disease, and we adopted the grid technique. Simply we deliver a high dose, 15 gray, single dose, then to be followed by 40 grays and 15. Originally, we should have used this applicator. This applicator actually is 25,000 American dollars last year, the price. Alternatively, we use the MLC. It serves the same, but it services the same, but it takes longer time on the machine. But we are experiencing very good experience, like Ihab said an hour ago. This is another poor patient who have been found to have a skull-base invading tumor with fullness on the left side of the nasopharynx, and she was started to be managed as a nasopharyngeal carcinoma till they got a biopsy taken, and somebody examined the patient and found to have locally advanced breast cancer and solitary isolated. So please, patients should be investigated thoroughly to make sure that she doesn't have anything else. We adapted VMAT for skull bone deposits. What we see here is the 95% in yellow, and the blue is 50% of the dose. It preserves the brain, and it keeps the patient alert with cognitive function maintained or well. Last month, we have observed that on right-sided breast cancer patients, the liver is receiving high dose unnecessarily. It's a big volume. This is a patient who has mastectomy on the right side, and what you can see here in yellow is the 90%, 95%. The blue is the 50%. The pinkish is the 40%. And the last turquoise is 20%. It's a big volume of the liver to be irradiated for no reason. So even if we apply VMAT or MRT, still there is a big volume of the liver receiving 50% of the dose for no reason. We don't know, does this have a reflection on the future of the patient or no? So we started to study it. We applied deep inspiratory, voluntarily deep inspiratory breath hold for such kind of patients having right breast cancer. And as you see, the deep respiratory breath hold worked nicely. It pushes the liver downwards. It's a very simple technique, and it needs some simple coaching. And of course, when we compare between free breathing style and deep inspiratory breath hold, there was significant reduction of radiation dose to the liver. When we compare the DVH, up there is the free breathing, and down there is the deep and passive threshold. You can see that the main dose dropped from almost 300 down to 47 centigrade, and different doses as well have been reduced to different volumes of the liver. Our vision for the for the Nasser City Cancer Center, that very soon we'll have our new Versa HD. On this side is our new machine at Breast Cancer Hospital, and on that side the proposal of the new machine. It doesn't look like this now. It will be in 6 months. We'll get similarity between the two machines. We'll do the acceptance, and we'll adjust the beam profile to be this guy is identical to that guy, and we can switch patients between very easily and very smoothly. So in conclusion, radiation therapy serves very well for radiation therapy for breast cancer with sustained curability, but we have to keep an eye on quality of life and cost. Breast comes in different shapes, different sizes, so there are different techniques to treat the breast. There is no one single technique that serves all breast cancer patients. It has to be clear that we should make the best use of the resources that we have, and of course, research research is the backbone of our practice on a daily basis. Thank you very much. I will introduce Dr. Raymond.
And now we will present Professor Dr. Raymond Ramses from National Cancer Institute and the lecture about metastasis-directed radiotherapy.
It's a privilege to be here in Onco Egypt in its third edition. And I'd like to thank the organizing committee and Dr. Imad for inviting me to this. I see the faces and I know how tired is everybody, so I'll try to be as quick, as focused as possible. And actually, Dr. Yasser and Dr. Ali made it much easier for me because they went over the technical aspects of SBRT and the metastasis-directed therapy. So I'm going to be talking about the literature driving this whole thing and how to pick your patient from the clinic. You know, traditionally, metastatic patients were doomed, and systemic treatment would continue till the patient is no longer coping up with the complications of systemic treatment. Then, in 1995, Hillman and Wieselbaum came with the concept, started to propagate the concept of oligometastatic disease, that is a state between localized cancer and extensive metastasis. And why we as clinicians should be trying to pick those patients, because they posed a unique therapeutic window with long-term survival that can be achieved. It wasn't until 2017 when the European Society of Medical Oncology tried to put a definition for oligometastatic disease. And this definition at that time was low volume metastatic disease, limited number and size of metastatic lesions up to 5, not necessarily in the same organ. 3 years later, the ASTRO and the ISTRO issued a joint statement about the definition of oligometastatic disease. Actually, they widened the spectrum. So we're no longer committed to the 5 or less metastatic lesions. They mentioned lesions that can be considered as oligometastatic disease was that the maximum number must be limited by the ability to deliver safe, curative intent metastasis-directed therapy. So we're no longer committed to the number of 5. And this definition actually reflected on most of the trial that started 2019 and onward. You can see the Supercomet 10, recruiting now, including patients from 4 to 10 oligometastatic metastatic lesions. The ESMO also classified the types of oligometastatic disease to those who are occurring with the diagnosis of the primary cancer site, and those who are occurring at a metachronous. Those could be oligorecurrences, oligopersistence, or oligoprogression. The hypothesis behind trying to treat metastatic sites on a curative intent is that you can reduce the volume of the tumor, and by doing this, you can reduce its detrimental effect on overall survival. You can reduce the cancer stem cells. You might have synergistic effect with systemic agents. And we know now we can see the reports coming about the interaction of SBRT, SABR with immunotherapy. Results are very promising. You can induce immunogenic response with the high doses of radiation you're giving every single fraction with the SBRT. You might be lucky and catch an abscopal effect. So it could be done with surgery. Any ablative measures could be done with SBRT. I'm showing here some of the surgical data for lung metastasis from breast cancer, and they have actually achieved up to 82 months of median survival. Good results for patients with lung metastasis. Again, for liver metastasis, the surgery series are results are good still, up to 58 months of median survival. And then came the stereotactic ablative body radiation therapy, or the stereotactic body radiation for those who are non-radiation oncologists among the audience. This is a method of concentrating radiation by irradiating cancer lesions from all directions, as you can see. It gives us high dose conformity and sharp dose gradient outside the radiation field. So is it effective? Those are some of the retrospective data that were published. You can see basically most of the sites could be treated with SBRT or SABR. Bone, lymph nodes, liver, lung, adrenals. You could achieve a 2-year overall survival of 95%, or even a 5-year overall survival of 83%. Those are high numbers. Those are true survival improvements. So why choose SBRT or SBR over other modalities? Because you can treat multiple sites on the same day on an outpatient basis. You expect rapid recovery, more suitable for patients with comorbidities or poor surgical candidates, and you could enhance the immunogenic response. In 2018, a landmark study was published, the Saber-Comet study. In the Saber-Comet study, they included 99 patients with 1 to 5 metastatic lesions, controlled primary tumor. They were randomized to receive either a standard of care versus the standard of care plus SBRT. The primary endpoint was overall survival. At that time, at the time they initiated this study, they were criticized for putting overall survival in those metastatic patients, as it was deemed too ambitious to look for overall survival improvement in those patients. So everybody at that time was trying to run after the progression-free survival. So what happened? 5-year overall survival improved from 17.7% to 42.3%. Those Kaplan-Meier's, I mean, when was the last time anybody saw this difference in the Kaplan-Meier curves? Probably people next door are talking about a fancy drug that costs gazillion of dollars to improve 2 months or 3 months in survival. But here we're talking about true improvement in overall survival. The 5-year overall survival is jumping from 17.7 to 43%. The NRG BR002, slightly disappointing. Why? They included only breast cancer patients, 125 with oligometastatic disease, 1 to 4 extracranial oligometastatic lesions, with a controlled primary, but they didn't define the intensity of systemic treatment that should be given. They didn't define when did they start calculating the progression-free survival. They included patients were advanced because they included oligoprogression and oligopersistent disease patients. So you would expect those results to be inferior. Actually, the two arms were comparable. The results were non-inferior, but you can see that the progression of the old lesions was 6.7% in the SBRT arm versus 29 in the systemic treatment arm, which means it's just they didn't pick the right patients for the study. SBRT did a good job. The progression occurred outside of the radiation fields. Those are some of the prospective studies, and I'm willing to give you a hint about the Egyptian National Cancer Institute study, our study. So we start randomizing oligometastatic patients. We stuck to the, we were committed to the definition of the ESMO by allowing only patients with 1 to 5 lesions to be included, and we would randomize patients at initial presentation to receive metastasis-directed therapy or the standard of care. And after receiving the metastasis-directed therapy, patients would receive systemic treatment for 6 months. And an added point, patients who would respond well to the metastasis-directed therapy and the systemic treatment would undergo loco-regional treatment for the primary. So we started accruing patients. We are recruiting currently. We have a good number of patients. And we expect to end this by October 2025. So the next point that I'd be talking about is what should we do in real life in the clinic? How should we pick our patients? What should we do with them? Ablate all metastatic sites, maximize safety and tolerability, careful patient selection, minimize treatment time, and it's better to have a resected or controlled primary. What about ablation of the all metastatic sites? You could fall into the dichotomy of the most of the SBRT studies that's tackling the point of the metastasis-directed therapy. Most of them are either treating certain sites and leaving the others for the systemic treatment. You could get the benefit of giving a high dose of radiation, minimizing the toxicity, but you're not treating all sites. Or you could treat all metastatic sites you have. And this is what you should do, because there's no data supporting selective SABR. Even if you're thinking you might treat one spot and expecting the abscopal effect, this is rare and ineffective in the setting of oligometastatic patients, so don't chase it. Don't try to bring the abscopal effect. A resected or controlled primary is important because it's necessary to hold metastatic dissemination and prevent local symptoms, and that would improve tolerability to the treatment you're giving. Also, it curtails the genetic diversity, crippling tumor evolution, and slow emergence of the therapy-resistant strains. Maximizing the safety and tolerability. This has been taken into account in the crafting the protocol for the SAPRCOMET 10. And this should be, I encourage everybody to read the protocol, and this should be your reference when choosing patients and when treating patients. They choose carefully the suitably ablative doses, and they put strict organ at-risk constraints that all of us should be committed when evaluating the plans for SBRT. Because toxic or risky treatments in those subset of patients may affect survival or at least quality of life. In metastatic patients, you wouldn't like to do this. So careful patient selection, age, performance status, minimal metastatic burden. Even if some of the studies are including patients from 4 to 10, with 4 to 10 metastatic sites, it doesn't mean this is the appropriate thing to do. Minimal metastatic burden has the potential of curing this patient. Also, metachronous presentation is superior to synchronous presentation. Those are considered the 4 ACEs for patient selection. Minimize treatment time. This is a crucial point. Treatment time is, it's recommended that you should finish your treatment over 2 weeks. Why? Not to delay the start of systemic treatment, to avoid widely disseminated polymetastatic disease. Even you could consider concurrent administration of systemic treatment. A temporal relation of radiation with immunotherapy is crucial and is important. You could give both. You could have the synergistic effect from adding the 2 lines of treatment together. So in conclusion, metastasis-directed therapy is effective to control limited metastatic disease. High-level randomized data are available to support its use. It is especially useful in breast cancer given its protracted course and prolonged natural history. Combined with the newer systemic treatment like immunotherapy and target therapy, this is showing promising results. Results of ongoing phase 3 studies are eagerly awaited. Thank you, and I'm sorry for keeping you awake till this time of the day.
Thank you very much, Dr. Rimon. And I think with that, we will conclude our session and the first day of Onco Egypt 2023. Thank you very much to all my dear chairmen and speakers for accepting our invitation to participate in this beautiful session. And see you tomorrow, inshallah.